Okay, so we are live in three, two, one. Then please start. We are live.
New is the year, new are the hopes, new is the resolution, new is the beginning. And Horizon Conference wishes you a very happy new year. Namaskar and good evening, everyone. I welcome you all for today's webinar on SABCS Highlights 2021 Potential Practice Changing Breast Cancer Trials. With immense pleasure, I would like to invite Dr. Bhavna Sirohi, Consultant Medical Oncologist, GIN Breast Cancer, Apollo Proton Cancer Center, Chennai, to set the ball rolling and take the proceeding further. Over to you, ma'am.
Thank you, everyone. I wish everyone a happy new year. And it gives me great pleasure to start off the session, the first session of the new year on breast cancer. And I must congratulate Dr. Ramesh Sareen for having put everything together single-handedly, the whole program. The program looks amazing, along with amazing speakers and faculty as well. I think she has divided it very nicely into practice changing data from San Antonio, but also view from the trenches. What will you do on Monday morning, which is what all of us think about when we attend any meeting, because we are here for our patients. So thank you, Dr. Sareen. It gives me great pleasure to request you to welcome everyone and introduce the meeting. Dr. Sareen needs no introduction. She's a very senior breast surgeon and mentor to so many of us. Please, Dr. Sareen. Thank you.
Thank you, Bhavna, and good evening, colleagues, the chairpersons, the moderators, the panelists, and the discussants, and the organizing team. And I speak on behalf of all of you and welcome you. The meeting is being organized by Indraprastha Apollo Hospital, Delhi, and Proton Cancer Center in Chennai. I welcome you all. As you know, that San Antonio Breast Cancer Conference is held every year in San Antonio in December. It's one of the biggest breast cancer meet. Major basic translational research is presented besides clinical trials, reviews, debates, and a special session of view from the trenches. What will you do on a Monday morning, which I find very interesting. Last year, the meeting was virtual, and this year the meeting was hybrid, but even then the number of people attending physically were very few. There used to be a large number of contingent from India when there were physical meetings, but now even virtual meeting, the number of people attending is very few because of the time difference, that when it's 12 o'clock over here, it's 1:30 in the morning over there, and it's very hard to keep awake from 12 o'clock in the night till 6 in the morning. So the time difference makes it difficult for us to attend. We thought that we should bring this meeting to the knowledge of everybody, and it brings important clinical trials which are practice changing. As you can see, that over a 5 days meeting is being abridged into a 6 hours meeting. So with this meeting, the fatigue does happen to the listeners after 2 to 3 hours. So, and we do want to present a lot of practice changing papers. So the time is very strict and the time is very short for each presentations, and the time maybe stuck to. And it's a request to the chairpersons to please see that the timing is kept, whether it's the presentation or the debate. The questions in the chat box have not been given any time, but I do request the moderators for the session of view from the trenches, what will you do on a Monday morning, may pick up important questions from the chat box and put it in their questions to the discussants. Wishing you all, and thank you so much for attending this meeting. And I wish and I hope that with this review. Our patients on a Monday morning with breast cancer will have better outcomes. And thank you so much for being here. And I hand over the mic back to Bhavna.
Thank you so much, Dr. Sareen. I think this is very important. The first session, I would love to invite two amazing surgeons from India, Dr. Harit Chaturvedi, whom I've had the pleasure of working with for a long time at Max Hospital, and also Dr. Vinay Deshmane from Mumbai. So Dr. Harit, please take it forward for the first session. Thank you.
Thank you, Bhavna. Thank you for the kind words. And I think we'll just move on quickly with the first presentation by Dr. Vedant Kabra on the SABCS abridged presentation on the topic Artificial Intelligence, Intelligent Vacuum-Assisted Breast Biopsy to Identify Breast Cancer Patients with Pathological Complete CR. So after neoadjuvant systemic therapy for omission of breast and axillary surgery. So I will request Dr. Vedant Vedant needs, again, no introduction for the breast community. He has been a very long-standing surgical oncologist, and right now he heads the FMRI and the Fortis Surgical Oncology Program. So with this, I want to request Vedant to take it forward.
Thank you, Dr. Chaturvedi, Dr. Bhavna, and Dr. Sareen. I've already shared my screen. I hope it is visible.
It is. It is.
Yes, sir.
Thank you. So I'll go along with the presentation. As we all know, overall complete response rates are somewhere between 30 to 40% in breast cancer after neoadjuvant systemic therapy. And it can go up to 70 to 80% in triple negative and HER2 positive groups. So we are doing a lot of unnecessary surgeries for breast cancers after post-neoadjuvant systemic therapy. However, assessment of response is not very good either clinically, radiologically, a combination of both, or adding image-guided biopsies also to it. Although the best false negative rates are achieved with imaging and image-guided biopsy, but they are not good enough. The target being above 90, less than 10% false negative rate. This trial was published, or this is a study published in 2018 using 40 patients only, reported a very good accuracy rate of 98% with an ultrasound guided or a stereotactic VAB. However, this never used MRI, which is the standard of care for assessment radiologically. It was a small study, included only triple negative and HER2 positive, although these are the two most important groups. However, what happened later on with other studies, these are larger studies, larger trials, some of them have reported results, interim or final, and you can see most of them have a very high false negative rate, up to 50%, 37%, and the best is 17.8% in those which are not acceptable. The smallest of these studies, conducted by Royal Marsden, Korea, and MD Anderson, had only 76 patients. They reported FNR of less than 5%, but the caveat here is we have to have at least 6 scores by VAB, and the residual abnormality should be only up to 2 centimeters. In those cases, the FNR was much better. So now with this, there was another abstract presented in this SABCS. This was a study, multicentric study from Tokyo, 88 patients. Again, 6 scores were taken, but the false negative rate was 33%, which is very high. So the summary of all these studies is that FNR is unacceptably high and it cannot be recommended as a routine. However, if we have to use it somewhere, probably it is up to 2 centimeters of residual abnormality and more than 6 VAB cores using a 10G or a thicker needle. This is still not standard of care, let me tell you. Some of the studies have found that stereotactic biopsy was better than ultrasound guided biopsy, but those studies also said that the number of cores removed by stereotactic was more than the ultrasound guidance. So that may have led to better false negativity in those studies. Now, coming to the abstract that I am presenting, this intelligent vacuum assisted biopsy, what is this? It is basically image plus vacuum assisted biopsy and some algorithms which are artificial learning, artificial intelligence algorithms. So this was presented as an abstract, and this is only one pager which I actually got till yesterday, but I could get hold of the same group having published a paper last year. This is responder group, and is a multi-centric trial from Germany, South Korea, USA, and UK centers. So what they did was they evaluated 4 multivariate algorithms using 19 variables, which are patient-related, tumor-related, and VAB-related factors. And these are the 4 multivariate algorithms of increasing complexity, the most complex one being deep multilayer neural network, which is also used for artificial intelligence reporting of radiology imaging. Now, what they did, they took 4 different trials, out of which the first 3 trials they used for assessing all 4 algorithms, and the 4th one they used for revalidation of the best algorithm. So the first 3 trials had nearly 500 patients, out of which 457 were included. Some were excluded because they were core biopsies or they were not using thick enough needle. Now they divided in a ratio of 2:1. So 305 patients were the training set for these algorithms and 152 patients were the test set. And let's see what has happened. Now, if you see here, the last row is the false or the accuracy of the intelligent VAB. If you come from above, only imaging 24% false negative, VAB alone 28%, imaging with VAB 12%. If you have a very good patient selection, may come to 4%, but intelligent VAB had a 0%. So actually, all the 4 algorithms individually had shown 1.2%, but in the final validation set, the neural network showed a 0% false negative rate, which was very good. However, specificity was not as good. And since it was a 0% FNR, negative predictive value is expected to be 100%. Now there was something called SHAP value. I don't know what exactly it is because the details of the algorithm was not given in that paper. So the SHAP value on the x-axis, if it is on the negative side of the 0, that means that this is an important predictor of PCR. If it is on the positive side, which is right side of the 0, then it is an important predictor of the disease. And then there are 2 colors that you can see. If it is purple color, then this variable has a high value. If it is a yellow colored variable, then it has a low value. And on y-axis are plotted various variables that have been taken into consideration in the algorithm. And higher on the y-axis the variable is, higher is its overall global importance for this algorithm. Similarly, in this, there are 2 colors, blue and red, and they are of various shades. So darker blue color represents a variable which will denote more importance in predicting residual disease, and a darker red color will predict no residual disease. So for example, at the top, you can see diameter after neoadjuvant systemic therapy. That's the darkest blue color in this figure. And that is probably has the maximum weightage for prediction of residual disease. Similarly, in the middle, you will see no tumor cells on VAB, which is the darkest red color. And obviously is the most important variable for predicting a complete response.
My apologies,
Vedanta, I'll
sir,
request
you
you
are
to
left
summarize.
with 1 minute.
Yes, 2 more slides.
Yeah,
So the
sure.
study conclusions are that intelligent VAB model has a very low FNR, which is 1%, and in fact in the validation study 0%. But they said that more complex algorithm performed the best, which is the neural network, and was further validated by the 4th study. And this present trial reopens the discussion about future management of exceptional responders, which until now the studies had not shown a very good FNR. So they suggest a prospective diagnostic or even a therapeutic trial to evaluate long-term oncologic effects of omitting surgery, which seems warranted as a result of this study. I'll not go into these discussion points and go finally to my take-home messages, which is that this is definitely a promising tool and needs further prospective evaluation. We must need a thicker needle and at least 6 scores must be taken. Now, how to deal with various subtypes is not very clear. Auxiliary response prediction is not done by this algorithm. So it is possibly going to be more applicable only to the CNO group right in the beginning. And can we avoid radiation as a part of de-escalation? Again, this study does not take that into consideration. Thank you very much.
Thank you very much, Vedant. I think we'll take the questions and discussion at the end of the session. So now I'll request Dr. Geeta to talk about the paper on presentation on trends in surgical resection stage 4 breast cancer. Less surgery, more systemic treatment, obviously. Yeah. Dr. Geeta, please. Dr. Geeta is again Senior Director and Breast Surgeon at Max Hospital. And she has been very much among the leading luminaries in this space. Thank you.
Thank you, Dr. Chaturvedi, for the kind introduction. And let me take you through this kind of interesting, because we keep talking about what to do in metastatic breast cancer. Should we do surgery or not? The debate continues. So here they're talking about the trends in surgical resection for stage 4 breast cancer, less surgery and to be more inclined towards systemic treatment. And this is a multi-centric study within the US led by Sasha R. Douglas. So this is, I don't think I need to really stress upon how we look at surgery in terms of metastatic disease. We do focus only on oligometastatic disease, but I can understand why this debate happened in the US, and you will also realize as we go along. So we do know that there are some retrospective studies which actually generated a lot of interest, which happened in the early 2000s, which started off with Seema Khan et al. And suggested a significant survival benefit of loco-regional therapy. But such benefit, which happened, was not replicated in the randomized controlled trials, which happened in 2009 with the Turkish trial, of course, showed it. But in 2014, when the Tata Memorial study happened, it did not show any benefit from loco-regional treatment. So in this study, what they were trying to do is trying to determine the national trends in surgical resection and other therapies for stage 4 breast cancer. So just to show you, there was a meta-analysis. If you look at this meta-analysis, looking at several thousands of patients, and they showed that there was some benefit for surgery. This is all retrospective. So then came the prospective randomized control trials, which was the Turkish trial, which said surgery is good, Tata Memorial, which said no, ABCSG, a poor accrual, not many patients were recruited to this, and they also said not much benefit with surgery, and so was the case with ECOG Akron 2108. So let me just take you through this study, because I'm sure that it is going to incite a lot of debate again. Because if you look at this National Cancer Database, which was queried to identify 87,000 plus women who met the inclusion criteria and diagnosed prior to surgery with de novo stage 4 breast cancer. This was between 2004 and 2017, of course, a retrospective study. And trends over a period of time were noted for those patients who underwent either breast conservation or mastectomy, and radiation, and then systemic treatments were compared. They also looked at one area which we don't normally look at, and that is the palliative care. And they also looked at predictors of those of breast surgery who opted for breast surgery in a uni and multivariate analysis. So if you look at the results, it is very interesting to see that how at de novo breast cancers were having surgery. There were close to 37% of patients in 2009. And then there was a decline to almost to close to half of what was being done in 2009 by 2017. And interestingly, the largest decline was seen in the hormone receptor positive patients and HER2 negative. Because in 2007, close to 70% of patients with ERPR positive were undergoing surgery, and this declined to 15% in 2017. Honestly, I'm not surprised, and I'll tell you why I'm not surprised. And also, for women who received systemic therapy prior to surgery, the median number of days that were there between the initiation of systemic treatment and surgery continued to increase over a period of time, from 140 days in 2004 to close to 167 days in 2017. In 2004, the rate of systemic therapy was slightly more common than the loco-regional therapy, with or without systemic therapy, which was close to about 48%. But by 2017, systemic therapy had occupied larger stage, and it was closer to 69%. And this is a very interesting slide because we seem to talk about palliative care and say we do not offer much of palliative care, but the US is also not very much better off. It's only 21% of patients who reported as receiving any kind of palliative care. Again, another interesting aspect, if you look at
1 minute.
Sorry?
You're just left with 1 minute to conclude your presentation. Thank you.
Just finishing. So if you look at the odds of breast surgery, you'll see this is at complete variance to what we do now. So triple negative, lobular, large tumor size, poorly differentiated tumors, isolated lung or liver metastasis are the patients who are likely to undergo breast surgery as compared to the group that we offer surgery now. So this was the conclusion that it is possible that it may be partially in response to the RCTs that happened, that the thought has changed, and also palliative services are either provided at low rates to women with stage 4 or are underreported. That is possibly the reason. So my takeaways is that this study is retrospective, and in this abstract, I could not see them qualifying metastatic disease, but possibly unlikely that the larger population would have been oligometastasis, and not surprised at the trend at all. It seems like quite a few patients were undergoing 37% is quite a large number of patients undergoing surgery. So that wanton use of surgery in metastatic disease has come down, and there is restricted use of surgery in biologically better behaved oligometastatic disease over the years because of the RCTs that have happened. And the odds of receiving a surgery in this study is in a very unfavorable group, which is completely at variance with the criteria that we used now in oligometastatic disease. And newer and more effective systemic treatment possibly help in defending both sides of the argument, whether you should be doing surgery or not doing surgery. And in carefully selected patients, I still believe there is a role for surgery in younger bone-only oligometastatic disease, HER2 positive or hormone receptor positive patients. Of course, more RCTs will be required. As far as palliative or supportive care is concerned, it needs to kick in earlier than later, especially in locally advanced breast cancers and de novo metastatic disease. And recognition of issues arising out of the disease or treatment, pain, and end of life care definitely needs to be dealt with more sensitively. Thank you very much.
Thank you, Dr. Geeta. I'll request Dr. Vinay is also there. So, Dr. Vinay, you please invite our next speaker, Dr. Sandeep Gupte, or I will invite him and then you will take off from there. So, Dr. Sandeep is a breast surgeon at Mumbai, and he is at Apollo Hospital and also at Mumbai Hospital. And he'll be talking about safety of conservative surgery with accelerated partial breast irradiation for isolated epithelial breast cancer and recurrence regardless of IST subtype. And Dr. Sandeep, please.
Yeah. Good evening, sir. Am I audible?
Yeah, you are.
Yeah. Thank you. Thank you, everyone, the organizing committee for this opportunity. In next 7 minutes, I'm going to talk about this abstract on the safety of the conservative surgery with accelerated partial breast re-irradiation for an isolated epithelial breast cancer recurrence, regardless of the IST type. So this is multicentric prospective study, and it has happened in the Barcelona, Spain, in 3 centers: breast, gynec, and the radiation department. So the background of the study was the standard of care everyone knows for the local recurrence after the BCS and the radiation is salvage mastectomy. But however, there is no solid data for proving a clear advantage of radical surgery for an IBTR in terms of the outcome for the patient with the isolated local recurrence after the BCT. So there are no published or ongoing prospective studies which compare the mastectomy versus the BCS alone with the patient with the IBR. So the author come up with this, there is growing interest in the feasibility of repeating BCS for this patient. So they analyzed the oncology outcome for the repeat BCS. So this study was happened between the period of 2014 to 26 years, although the patient numbers are very less, 35 patients were selected for the second BCS as a new lumpectomy with partial breast radiation, and they followed in this hospital. The criteria of the key eligibility criteria for this patient was mainly the patient was about the 50 years of age. The time from the primary treatment was 48 months from the previous radiation. They were isolated IBTR, no multifocal tumors on MRI. Tumor a bit small, less than 2 centimeter, and there was no primary major side effect radiation side effect. And finally the breast volume, the external volume ratio should be favorable for the BCS. So they were all favorable. The factors that has been chosen for this group. The results there was in 35 patients. There were, if you see the 86%, 30 cases were the invasive carcinoma, and 5 cases were the DCS. This chart had clearly mentioned this type of the tumor, the grade, ER positivity, the HER2 positivity, and KI. If you see this, the majority of the tumor around 77% were the invasive carcinoma. There were no the invasive lobar carcinoma. The most they around 50% were the modular differential carcinoma. 80% of the patient were the ER positive. So good prognostic. Again, the HER2 non-expression around almost 48%. And the care 67 is less than 20% in almost in the 50% group. So all they were good favorable local recurrences that chosen. In terms of the location, the like other tumor, these most of the recurrence was in the same quadrant, almost in the 48%, and in around 40% the quadrant were different. We talk about the type, the subgroup, the among the luminal A, B, the luminal B and HER2 positive, triple negative. If you see the luminal B were standing around 40% in this group. So all the patients treated with this wide excision with the accelerated partial breast radiation, 67 were treated with the IMRT, 27% treated with the 3D-CRT, and 6% with the IORT. There were 3 triple negative patients who received the adjuvant chemotherapy, and there were also HER2 positive patient who received the target transplant with the chemotherapy, and 1 patient received the only transplant without chemotherapy. All HER2 hormone positive patient received the endocrine treatment. There was median follow-up 37 months, and among them there were 4 relapses. So one was a second IBTR with a DCIS, and there 2 after the invasive carcinoma. There were 2 deaths which was not due to the breast cancer. The interesting part was the second IBTR, the rate was around 2.85%, and the 5-year the regional free survival, metastasis free survival, and the overall survival was almost around 82.4% versus 84.6%, and the 93% respectively. In conclusion, the conservative treatment with the breast conservation surgery and the accelerated partial breast radiation for an isolated tumor with the recurrence after BCS seems to be a feasible technique of an alternative to mastectomy in a selected group of patients. Second, local recurrence and the overall survival were similar to described before the salvage mastectomy. And the most important thing in this cohort, the IC subtypes with the poor prognosis like the HER2 positive and triple negative did not show any increase in the local recurrence after the BCS. So the take-home message for me is the good concept for a selected group of patients, but it needs a good validation in a large cohort. The prospective clinical trials are needed to clearly define the selection criteria and long-term local control and the toxicity. And the increased risks of severe toxicity should always be weighed up against the potential clinical benefit, and need to keep the lung and heart dose in check, especially on the left side. Thank you so much. I hope I'm within time.
Dr. Harit, Dr. Deshpande.
Yeah, I'm here. Am I audible, Dr. Sarin?
Yeah, you are now.
Yeah, okay, sorry, I was not. So Dr. Vinay is there. I will request him, or I'll invite Dr. Shalakha. Dr. Shalakha Joshi is Professor and Consultant Surgeon, Department of Surgical Oncology at Tata Memorial Hospital. And today she is talking about patient reported outcomes, PROs, for the intergroup Sentinel MAMA study and persistent impact of axillary surgery on arm and breast symptoms in early breast cancer. So Dr. Shalakha, please.
Thank you, sir. I'm hoping I'm audible enough to everyone.
Yes.
So the concept of observing a clinically node negative axilla is not really new, and it existed even back in the NSAP B04 study, which had an arm which offered only axillary observation. And one would expect a 40% rate of local axillary recurrence, as the occult nodal positivity was seen to be 40% in the arm which had axillary lymph node dissection. However, that was not the case, and much lesser number of patients really record in the axilla. Without getting into the controversies of why this happened and the small sample size, etc. of the study, we have now accepted that an FNR of less than 10% is good enough to have no detriment in long term with respect to local, axillary, as well as distant recurrences. And not doing the complete axillary lymph node dissection is acceptable in node negative patients. And this is mainly with respect to the concept of reducing the morbidity of complete axillary.
All are requested to join.
Sensory deficit. Now, there are many trials which have looked at conserving axilla, even in micrometastatic setting, and trials are underway which are looking at conserving axilla when there are macrometastases present in the lymph nodes. I'll be talking about this abstract, which is looking at the quality of life analysis of the INSEMA study, which is a step forward in this situation where the authors have chosen in the T1, T2 patients who underwent a breast conservation surgery and post-op radiation to not have any axillary surgery at all. So the randomization is in a 1:4 manner to get an SLNB versus not doing anything. And they introduced a second randomization in the study, which was in 1 to 3 positive sentinel lymph nodes, who were then randomized to receive complete dissection versus not. The primary endpoint of the study is invasive disease-free survival in the first randomization, and a key secondary endpoint is invasive disease-free survival in the second randomization, that is leaving behind a positive axilla. And a quality of life analysis is an important secondary endpoint. The patient-related outcome measures were done at baseline and subsequently for up to 18 months. EORTC, QL2, C30, and BR23 questionnaires were used. Higher scale of C30 score indicates better functioning and global health status, whereas a higher score of BR23 questionnaire suggests worse symptom severity. All patients, please note, had breast conservation surgery, and the authors claim that axilla was not included in the clinical target volume of radiation. So this is the final randomized patients. And if you see the baseline characteristic in the first randomization set of patients, median age was 60 years, majority, almost 90% patients were T1. Majority of them were actually more than only grade 1 and 2. That is 96% were grade 1 and 2. 98.5% were ERPR positive and very few were HER2 positive. Even in the second randomization, majority patients had small tumor size, 80% were T1, majority were low grade, and a lot were ERPR positive and very few were HER2 negative. If you look at the overall quality of life analysis with respect to the global health status, physical functioning, emotional functioning, cognitive functioning, social functioning, body image, etc., there was no difference in the two arms at 18 months. And the only difference that was seen was in the breast-related axillary symptom score on the BR23 questionnaire, which was better in the no axillary surgery arm. That is, the patients who did not even receive any sentinel lymph node biopsy. And this was clinically significant. Also, if you look at the second randomization group, there was no difference for global health status, functional scales, or any of the body image scales in the two groups. However, as you would expect, the patients who had only sentinel node biopsy, even in node positive axilla, had much better arm-related symptoms with respect to pain, arm swelling, and shoulder mobility. And this was seen across both the first and second randomization. So to conclude, the authors said that the quality of life is better with respect to arm-related symptoms in patients who did not undergo any axillary surgery for clinically node-negative axilla as compared to doing the sentinel lymph node biopsy, and for those who had 1 to 3 positive nodes who did not undergo any completion axillary dissection. However, all the other global health scores remain the same in the two arms. And this essentially is again a very good prognosis and a very good biology set of patients. I don't think the authors have said how many of them are screen detected. And of course, you are awaiting the final survival results, which are expected by 2024. Again, when we try to put this study in the Indian perspective and look at the West versus East divide, we know that majority of the patients diagnosed in the East are confined to the primary, and really very few are even reaching the axillary lymph nodes. Whereas what we see in India is at least 50 to 55% patients who undergo upfront surgery are node positive, and a high number of patients also have a level 3 axillary involvement. However, we have accepted either a sentinel node biopsy or any other low-cost substitute of the same in the form of low axillary sampling as a procedure of choice in node-negative axilla. And if these are negative, we do not complete the axilla now in node-negative patients. However, to put the ACOSOC Z11 study in the Indian perspective, when we compare it with our own data, We have a much larger size of patients. We do not see micrometastasis that often. We have a higher grade of tumors, and the additional lymph node burden is much higher. So we do need to take this entire leaving behind axilla when the nodes are positive concept with a pinch of salt. And to keep in mind that the EPISOC Z11 study was actually planned with a 5% acceptable detriment in survival. So when on one hand, we are trying to escalate chemotherapy, targeted therapy, and radiation therapy portals to include regional nodes in the irradiation portal, and these are based on small benefits in superiority trials. We're trying to de-escalate surgery based on these non-inferiority trials with probably an acceptable small detriment. I really think that a very important part of quality of life is life itself. And if you take the life out of the quality of life, we need to rethink the whole strategy. Thank you for giving me this opportunity to talk here. And I'm sure my moderators are later going to summarize the study.
Thank you, Dr. Shah. Thank you. And with this, I will invite Dr. Vani to really moderate this, a wide spectrum of presentations on various aspects of early breast cancer. And the discussants are Dr. Kanchan Kaur and Dr. Gaurav Agarwal. So all three of them are very well known, and I'll request them to take it from here.
Thank you very much, Dr. Harit. Actually, your audibility is not very clear, so I couldn't really hear much. Thank you very much.
You're audible, yeah.
Yes. Thank you. I can hear you also now better. Thank you very much. I'm just going to share my screen first. 1 minute. Is my screen visible?
Yes, ma'am.
Yes.
Thank you very much. That was actually a very concise and well presented 4 abstracts. Let me first invite my discussants, the 2 discussants for today for all these 4 abstracts, Dr. Kanchan Kaur and Dr. Gaurav Agarwal. Are they with me today? Dr. Kanchan Kaur and Dr. Gaurav Agarwal?
I saw them in between. I saw Dr. Vinay also in between, but Dr. Kanchan Kaur.
Kanchan is there. I can see her.
Yeah, I can see her.
Kanchan Kaur? Kanchan, are you there?
I'll call her 1 second.
I don't even see Gaurav, so.
Gaurav is not there, yeah.
Okay, Gaurav has not joined in. All right. Is Kanchan there? Geeta, could you get through to her?
I'm just calling her. Hi, Vani.
Yeah, I'll just check on Gaurav as well.
I think she's on the phone. It's busy. You can start, Vani. Maybe
Yeah, Vani, you can start.
You have Geeta, Harit,
Yes.
Sandeep, Shalak,
Right.
all of them.
So let me take their roles as well currently as I start off on these 4 abstracts.
Sure.
An interesting way of looking forward, having 4 important areas being covered. The abstracts we just heard were essentially 4. First, of course, was the artificial intelligence guided vacuum assisted biopsy to identify path complete response post neoadjuvant chemotherapy, and then a daring proposition for omission of breast and axillary surgery. This is, of course, again challenging the surgeons, saying that the role of surgeons is reducing in these patients as well. And mind you, these are the post neoadjuvant chemotherapy larger tumors. Second was, of course, trends in surgery in metastatic breast cancer. We do know there have been some trends, and this has been very well shown and documented in this particular abstract with necessary and more systemic therapy. The third was a re-irradiation with accelerated partial breast irradiation for ipsilateral breast tumor recurrences, and again, irrespective of tumor biology. And the fourth, as I see, was the PROs or patient-reported outcomes in sentinel node studies in early breast cancer. Starting with the first one, the artificial intelligence guided WAB to identify post-neoadjuvant patients, and to then consider the patients with PCR for omission of breast and axillary surgery. Now, as I understand, this is basically a small study, 318 women only. And what they have really looked at here is the false negative rate compared to surgery. And the false negative rate was reported as 4%. That is probably the primary endpoint reported here. But what would be really, and they've also gone ahead to say that the omission of breast and axillary surgery for exceptional responders or those who have a PAT-CR may be then evaluated in future trials. It's actually a bold proposition as I would see it, but then that is the way we are heading these days. If you look at it for early breast cancers, we've already started accepting node negative by any kind of evaluation, say a sentinel node or in sentinel node biopsy being negative, we have stopped doing axillary clearance for early breast cancers. But as far as the post-neoadjuvant chemotherapy is concerned, this is a different subset. So is Kanchan and Gaurav, are they there with me again? Let me ask.
Yeah, Gaurav is also joined and Kanchan is also there. Both are there.
Perfect, perfect. So because these questions are going to be put across to them. So the first is, of course, that I want both their opinions, Kanchan as well as Gaurav, on safety of omitting breast surgery in post-neoadjuvant chemotherapy. I know this has been well alluded to in the presentations in the previous presenters, but I think I would like to see their important points on what do they feel the safety of omitting breast surgery. Kanchan, we can start with you.
Hi, sorry. I didn't hear I just joined. Can you please repeat the question? Safety of omitting surgery in post NSET, is that right?
Exactly. So we've had this abstract which was discussed just previously, where we looked at the VAB used to identify patients who had PAT-CR, and then the authors have gone ahead to suggest that if we have a PAT-CR, we could possibly and correctly identify it because their false negative rate was only 4% in that particular audit. They are proposing that we could even omit breast surgery in such patients post-neoadjuvant chemotherapy.
So yes.
Your opinion for safety of omitting breast surgery post-neoadjuvant chemotherapy?
So I think the debate is still ongoing and complete safety data is still not out. And when we are looking at omitting breast surgery post NACT, we cannot consider the breast and not consider what we are doing in the axilla at the same time. So we have to look, if we are looking at safety of omitting surgery for the breast, what are we going to be doing for the axilla in the same sitting? I think that question needs to be answered as well. And because the data is still not out there, and when you look at all the studies that have looked at how we are able to evaluate the response without doing surgery but with, say, VAB, which is either stereotactic guided. I know addition of an AI in this study seemed to have significantly, reduced the FNR to almost zero. So that is tempting, but I don't think at present it is practice changing, but definitely tempting enough for us to want to try and see in clinic what are rates of FNR in such patients if we do a VAB with a completion surgery to look at our results would be.
Gaurav, what's your opinion? I mean, not just identifying PAT-CR, but is there a role of an index tumor bed excision as well? So what is the evidence today as far as the omission of breast surgery is concerned, as regards the recurrence rates or outcomes? Gaurav? Is Gaurav with us? I can't see him, but can anybody check on that? Is Gaurav with us?
So Dr. Vani, if I may just, if as, I really like Dr. Shalaka's second last slide where she said that in everything we are happy to escalate, whether it's chemo or radio, but what is always a very definitive part of treatment, which is surgery, based on non-inferiority data, we are happy to look at de-escalating. Also, as you said, the representative tumor bed. Now, what constitutes a representative tumor bed? Now, if the patient has not had a shrinkage, which has been very centripetal, what if there has been Swiss cheesing of the tumor? And then how do you know what is the actual tumor bed? Now, in a patient in India where your tumor size would be, say, 5 centimeters or 6 centimeters, how do you know it's not like it's going to collapse like a black hole and you'll be able to pick up just the center and then confirm. So I think unless you are very, very thorough with your your radiology, unless you're very thorough with understanding what the tumor biology is, how the patient has responded, I still think this is a debate where even just pure MRIs are not able to pick up residual disease, pathological CR with a great degree of certainty. And then you bring in WAB, which hardly any centers offer, and that also, it's so operator dependent.
So as I understand from what you've also been saying is, and what the previous speakers have said, is as far as the breast surgery is concerned, we do have data, and that's good enough data. The EBC TCG meta-analysis clearly showed us the high local recurrence rates that were seen post-neoadjuvant chemotherapy primarily happened where there was no surgery being offered to the breast. And keeping that as a very strong indicator to accept now that you can safely omit breast surgery just because your core biopsy or a WAB has, even if it is AI guided, has somehow ended up picking up PATCR. Is that convincing enough, or is it complete enough to evaluate the tumor bed is a big question. And what you brought up is very important. If you have moth-eaten appearance or a tumor that doesn't really have a centripetal response, in such situations you are going to have residual disease and a high local recurrence. Second, of course, is the omitting of axillary surgery post-neoadjuvant chemotherapy. And again, what's your take on that? Because the kind of false negative rates that we do see post-neoadjuvant chemotherapy in axilla, would it still, even if it is an AR guided, would it be safe enough in our patients to have axillary surgery being omitted?
So all implicit Western data is very tempting, to read on a Friday, but definitely not convincing enough in our clinical practice to employ practice on a Monday. So all the data that we look in the West, when you have 90% plus tumors which are T1, when your nodal positivity rates are so low, then yes, the thought process of omitting axillary dissection should be the next course of thought process. But I think in India we are still not ready. Maybe in a very, very high select group of screen detected patients in centers that are doing very high end breast work, but not as a routine practice changing.
Right. So that's an important point to note. As far as the studies that are concerned in the West, as we have seen, their nodal positivity is low. It's also because the patients receiving neoadjuvant chemotherapy are not primarily locally advanced cancers or large operables. They are anything 3 centimeters and above would probably receive chemo, maybe even smaller tumors. And they would probably be guided by tumor biology. So if there's a triple negative or a HER2 positive, they would receive neoadjuvant chemo even in an earlier stage. So such studies would have looked at tumors which really are not really eligible for receiving neoadjuvant chemotherapy. Maybe they were suitable even for breast conservation upfront as well. Now, in such a situation, it's a completely different response that you see. It's a different kind of an outcome. And obviously, the recurrence rates are going to be completely different. Now, if you look at our own tumors, the biology is bad biology. Your negative tumors, triple negative tumors, HER2 positives, large tumors, and these are patients who receive a neoadjuvant chemotherapy. So I think there is a completely different set of patients you're talking about. We do know that those who have a complete response do better. Those who don't do worse. But again, the hormone receptor negativity and positivity makes a very major impact. And this is the data that I was alluding to, where the EBC-TCG meta-analysis clearly showed that there was a 13% recurrence whenever there was omission of breast surgery in these patients. Now, again, this is data from yesteryears. The chemotherapies were different, but yes, we do find that when there is no surgery offered, the recurrence rates are much higher. So it becomes really now coming down to a point where how well and how precisely can you identify PCR? And if this is there, that you can identify PCR better, you know that imaging misses out quite a bit. And of course, the core biopsy, as we have seen in this, does have a low FNR, but even FNR of 5% or 4% would probably have a negative impact if you have a bad biology disease. And finally, the outcome of interest remains locoregional recurrence and survival. I don't think there's anything else. An FNR does not really have any meaning as long as you have large tumors, bad biology. So for us to take this as an indication of omission of surgery, I think we're still not ready. We're not there. Globally also, I'm sure this is not going to be an acceptable data till we have survival impact very well known.
Can I quickly say something here?
Sure, sure.
So the whole idea of introducing NACT so aggressively in operable cancers is because we want to use PCR as a surrogate marker for prognosis. And then if we are not willing to go the entire length to confirm whether the patient has received PCR or not, I think then the patient might as well just have surgery upfront.
Right. Okay, moving on to the next abstract, interesting one. Again, trends in surgery in M1 disease. I think this is very clear to and evident to all of us. We do know what the reasons are as well. There is clear evidence that offering surgery in M1 disease, now with prospective randomized trial data being available, also our own data from Tata Memorial Center being available, we do know that surgery for these patients would probably not be offered. The role is only palliation. However, there was a time in the retrospective data where you had patients with oligometastatic disease who were being offered surgery and had shown survival benefit, but that has now been refuted with the evidence coming in from randomized trials. So what this particular abstract did was to show the trends related to surgical resection and other therapies based on evolving evidence of, and I feel this is more impacted because of the RCTs that evolved around that time and started in those days. They've really earmarked 2009 to 10 as the point of change. And as you can see from the graph, there has been an increase, a steady increase of systemic therapies only, a reduction in locoregional therapy. I think this speaks for itself. It clearly indicates the time when the controversies were really identified, that this was primarily because oligometastatic disease was being included in the retrospective data, prospective trials started. And I think that's a good trend that we see. So in M1 disease now, we have 50% reduction of locoregional therapies being offered. We have systemic therapy as the primary line of treatment, and I think we are on the right track here. So do you have any other comment, Kanchan, on this?
No, not really. I think the only thing that data like this brings up is that as doctors who treat breast, we will continue to go between whether it's a systemic disease and whether it is a local disease. And the only thing that I have to add here is that a lot of times, and I'm sure you face it as well, that patients in our clinics with metastatic disease end up needing surgery more for local control. So over here, we're not looking at improving their survival by doing the surgery, but as part of palliation. And yes, randomized control trials showing less and less survival benefit of surgery in such patients. I think this is one scenario where I'd be happy to hand over the patient to the medical oncologist and the radiation oncologist for management.
Absolutely, but the palliative role of surgery still remains. And I think the take-home message here is that as far as today the treatment of M1 disease is concerned, de novo metastatic, I think surgery remains to be a palliative intervention. There is no role of offering them in patients who respond to systemic therapy. As long as they're responding, continue the systemic therapy and limit the surgical interventions only for those who have large palliative bleeding disease. In such situations is where you would probably offer surgery. The third abstract was talking about re-irradiation in patients who had had breast conservation surgery and ipsilateral breast tumor recurrence in the form of APBI, and irrespective of tumor biology. These are the two important points they brought in. Now, as far as it's concerned, Kanchan, what do you think is is biology of disease to be considered when you're doing an upfront APBI?
That's part of the ASTRO guidelines for selecting patients for APBI. The age of the patient, ERPR strong positive, HER7 negative, node negative patients. In fact, we do offer APBI to our ERPR strong positive elderly ladies who are node negative and have screen detected small tumors, and anecdotally have around 8 or 10 patients in whom we've done this with good effect. But yes, for more aggressive tumors in younger patients, APBI is not the standard of care.
So as far as evidence is concerned, yes, biology of disease does have an impact, and Kanchan referred to the guidelines. So let me just move to the guidelines after this. I want to again come back and discuss on how will it impact on recurrent cases when you're talking of upfront APBI indications as well. And this data that has been presented is basically a small data in 35 patients over 6 years. And they have 11% recurrence rate. That's quite a huge recurrence rate if you look at it. So I think there is something that's missing over here. Now, if you look at the guidelines, the ASTRO guidelines clearly does include ER positive as the good indicator of suitable patients for APBI, but ER negatives move into the cautionary group. They do not actually look at HER2 status at all in the guidelines. As far as even the updated ASTRO guidelines that came up much later is also just looking at age groups, and they have differentiated age, but they have not really included anything else in the biology per se. Now, if you look at the guidelines that have come from Europe, here again, they are not considering the ERPR status at all. I mean, any is included in both good candidates as well as intermediate risk, whereas HER2 is again not being included in any of this. We looked at our own data from Tata Memorial. This is 157 patients treated in TMC with a median follow-up of 35 months between 2012 to 2016, a median age of 60 years, median tumor size 2.1, very ideal, fitting into the suitable candidate, and some of them in the intermediate. The molecular subtypes luminal A were 34%, luminal B 36%, triple negatives were 18%, and HER2 positives were 10.8%. And only 1/3 of these actually received Herceptin as a treatment. Now, what is interesting here is if you look at the local recurrence rate, the HER2 the 3-year local recurrence, 87.5% of them were really, they had the worst outcome as far as the brachytherapy is concerned. So this does bring us to a point that, HER2 positive patients who are not receiving a targeted therapy treatment would probably have a higher local recurrence rate. And we may want to review the situation. And mind you, this is upfront situation. And we are talking about a re-irradiation in patients with APBI when there is a recurrence, and irrespective of biology. I think that has to be taken with a pinch of salt, because you cannot really accept poor outcome patients to do well with limited disease. I can understand luminal A, and if you have an adequate test issue, you can go ahead and do a re-excision and probably treat them with APBI. What we really need in this again is to have a long follow-up and larger, data on outcomes. I don't think it's currently acceptable, but yes, we have to wait for some more studies to come back with the data, and that probably will give us a direction. But as far as the treatment today is concerned, I don't think it's yet ready for our clinics. The last but not the least is the patient-reported outcomes from the INSEMA study. Again,
I request you to summarize quickly.
Yeah, I'll just summarize.
1 minute left.
It's just last.
My apologies.
Last
Yeah.
time. Yeah. So no axillary surgery versus no axillary surgery being offered in those who are clinically node negative versus those who are sentinel node negative or sentinel node biopsy done versus those who have axillary lymph node resection. What they have reported here is only the patient-reported outcomes. But I think what is more important is to understand the biology of disease. No axillary surgery being offered in a clinically node negative Indian patient. I think there's going to be a little more deeper introspection to be done here, because we are talking about patients with a different biology and much more higher nodal burden. The results, of course, what we are seeing in the PRO, the patient-reported outcomes is very expected. If you do not do any surgery, the arm symptoms as well as the breast symptoms would be the least. If you do axillary lymph node resection, they would probably be the highest. But what would be the ideal outcome to assess in such a patient would be the primary endpoints of this study. That means the survival outcomes, and we really need to wait for the survival outcomes in these studies to accept. That's the my take on all these studies, and thank you very much. Thank you, Kanchan, for being there and discussing this out. So thank you.
Thank you, Dr. Vani, Dr. Kanchan. Thank you, and give it back to the organizers, Dr. Bhavna and Dr. Ramesh Sareen, for taking it forward. It's a wonderful session. Thank you.
Thank you so much, Dr. Harith. That was great, and excellent surgical session and a lot of learnings as well. Dr. Vinay, do you have any comments to make? Is he here? So great. I think let's move on to the next session. Dr. Julka is not well, so he will not be able to join us. So I'd like to invite Dr. Piyush Bajpai to kickstart the first lecture on endocrine receptor positive early breast cancer. Dr. Piyush Bajpai from Delhi.
Thank you, ma'am. Just share my slide.
Thank you.
Are my slides visible?
No, sir.
Yes.
Sorry, are they visible?
No, sir. You need to share the screen, sir.
May I request the chairperson if the next talk could be proceeded with, and I'll just
Sure,
try
sure.
to
No
finish.
problem.
Yeah.
Dr. Piyush, can I request Dr. Priya Tiwari to please give her lecture? Dr. Priya, are you here?
Can see it now.
We can see it.
We
Dr.
can see it
Piyush.
now. Yeah, why don't you go ahead actually?
Okay.
Yeah.
Okay. So apologies for that delay. Thanks to the organizers and chairperson for providing me this opportunity. The two topics, the two abstracts which I'm going to present is the adjuvant palbociclib in HR positive subset. And this was a big trial, 5,760 patients, PALAS trial. And of course, the monarchy trial, which was adjuvant abemaciclib. So just a brief background that we know that ER positive breast cancer, definitely adjuvant endocrine therapy is our current practice, and it's been extending beyond 5 years, and we all know this, and we are really concerned about the high risk population where the node is positive, younger age group. So these are this is the population where we actually look to go beyond hormonal therapy. And can CDK4/6 inhibitor enhance this or fill up this space? So that is the concern which was being addressed. And we know since this is some recent data, we have to look into this particular graph, of course, and it always reminds us that whenever we talk about ER positive breast cancer, we need to follow up these trials continuously on an annual basis and find out whether the curves are really separating or probably how would the results be. So talking about the CDK4 inhibitors, and we have data for the metastatic treatment naive patient, and where we found that they did definitely improve the PFS and did make an impact upon the overall survival. Well, the drugs, there have been always a debate whether they are all the same drugs or they are different. And of course, on the in vitro analysis, there have been some differences in how they inhibit the kinones, but otherwise, in metastatic breast cancer treatment naive, the curves were almost looking quite similar. So coming to the first trial, the PALAS trial, which actually took stage 2 and 3 HR positive patients who had completed prior treatment with the surgery, chemotherapy plus minus, and radiotherapy. Within 12 months of diagnosis, they were to be enrolled into the trial within 6 months of starting adjuvant endocrine therapy. And the tumor block was to be submitted. And stratification was between 2A versus 2B and 3 here. 2A has been taken. Chemotherapy or age less than 50 versus more than 50. And palbociclib was given almost for 2 years with the usual protocol. Endocrine treatment was aromatase inhibitor and tamoxifen plus minus LHRH agonist was allowed. So duration at least 5 years. Primary endpoint over here is IDFS as per the STEEP criteria, and the secondary endpoints were also there. There are other biomarkers which are being studied. So the analytical plan was the target hazard ratio was kept at 0.75 with 5,600 patients providing 85% power with one-sided alpha of 0.025. So analysis was done at 3 steps. The first, the futility 167 events. The second, efficacy and futility 313 events, and final analysis 469. So if you look at the baseline data, the baseline characteristics, with the majority of patients being in high stage disease pattern, but 2A was also there, 2B and 3 nearly constitute 82% of the patients over here. And median age was a relatively younger age group, 52 years. Clinically high risk, nearly 59% of the patients. Now, this graph shows, this table shows that how palbociclib was, there was discontinuation of the drug. And eventually at 24 months, nearly 44.9% of the patients discontinued palbociclib. And this is a real challenge to add CDK4/6 inhibitors. And we realized that they cannot be added like we add hormonal therapy. So final analysis data confirm earlier results that longer palbociclib duration or greater than 70% dose intensity did not markedly improve IDFS. This was the primary endpoint, IDFS, and we found that it was found that at the end of nearly 4 years or projected, there was no difference between the treatment arm, the comparator arm, and the experimental arm. Of course, the subset analysis also no significant difference either ways. Again, the secondary endpoints were not quite getting benefited. So to summarize, the authors concluded that the addition of palbociclib to adjuvant endocrine therapy did not prolong the IDFS, which was the primary endpoint, compared to endocrine therapy alone. And analysis of clinico-pathological subgroups did not identify a population of patients receiving benefit from adjuvant palbociclib, although limited by a small number of events. Of course, no new toxicity was observed. There is a trans-PALAS study which is going on the blocks and the liquid biopsies which have been conducted, and this data is to be seen further. Monarchy study design, again, quite a similar population, but this time it is slightly more high risk. If we see more than 4, there are 2 cohorts over here. And cohort 1 is actually taking the TNM high risk over here. More than 4 axillary lymph nodes or 1 to 3 axillary lymph nodes with at least one of the following: grade 3 disease or tumor size more than 5 centimeters. The cohort 2 is based on Ki67, which has been always under controversy. So 1 to 3 axillary lymph node and Ki67 more than 20% over here has been taken as a cutoff. So probably dictating more of a biology. No grade 3 and tumor size not more than 5 centimeters were also taken. So randomized 1:1 with abemaciclib 150 mg twice a day with endocrine therapy. And this was given up to at least 2 years of treatment, CDK4/6 inhibitor. Baseline characteristic, we see the median age again over here is 51 years. And we see that less than 65 years constituted nearly 84% of the patient. Again, high risk, as we can see, more than 5 centimeter tumor size, nearly 21.6% of the patients were having it. Grade 3, 38% patients, and Ki67 more than 20% was nearly 44% of the patients. The primary endpoint was IDFS, again over here, which was actually met on the initial analysis and the later follow-up data also. So here, the curves were separating at 2 years, and they further separated. At 2 years, this data was presented, and then again, at 3-year rate has been presented, and this is increasing. So the delta is increasing between the curves. So the IDFS rate, the hazard ratio is 0.69, and therefore a benefit of 30.4% reduction in risk of developing an IDFS event. Absolute IDFS rate between the two are 5.4% at 3 years. If we look at the cohort with a KI67, which was higher, more than 20%, there is a more benefit was seen, 33.7% reduction of developing an IDFS event, and absolute benefit ranged to up to 6% at 3 years.
My apologies, sir. You are just left with 1 minute to conclude your presentation. Thank you.
KI67 as a prognostic marker in cohort 1 was looked upon, and it turned out that it was a prognostic marker only and not a real predictive marker. As we can see, the dotted curves, the curves with the KI67 more than 20% definitely are lower. Abemaciclib does make some impact in separating the curves in both the dotted as well as the joint line curves. So here, if we see KI67 is a prognostic, it is benefiting less than and more than 20% as well. The toxicities are as expected with the abemaciclib. Diarrhea is something which we are concerned, and there comes the issue that how to actually go ahead with 2 years of abemaciclib always in a adjuvant setting. So the conclusion over here was that at the pre-planned analysis with 395 events, an additional 3.6 months median follow-up, there was continued reduction in risk of developing IDFS and DRR distant relapse-free survival events for patients with HR positive EBC. And this resulted in a statistically significant improvement in IDFS with high greater than 20% KI67. Safety was consistent with the IA2 and known safety profile of abemaciclib. More discontinuations due to adverse events occurred within the first 5 months of the study. So this was a positive study overall and led to the FDA approval over here, especially in the high risk recurrence and KI67 score of more than 20%. This is some major advancement in adjuvant setting. So if we just go across the 3 trials, the Penelope B, which was also taking palbociclib for a year. Here, there is these trials are quite similar. PALAS has a slight moderate to high risk population. But one thing important is that the discontinuation of the study treatment, palbociclib, nearly 42% patient dropped on that, and 17.4% on monarchy. So my take would be, would the significant results persist with longer follow-up? That is important to see. Yes, it is always relevant with ER positive, HER2 negative adjuvant setting. Now, why are the results different from other adjuvant clinical trials in this abemaciclib trial? So there is no clear idea. It is whether the drug is different, or it is because of the intermittent dosing pattern or patient compliance. Probably neoadjuvant trial could answer better. How do the results impact clinical practice? Should all patients receive abemaciclib? It becomes important because this is a positive trial. IDFS difference is actually growing. Now we need to see whether the curves separate or they probably merge. This is of course important, but now it has been separating, and therefore it should form an important part of discussion with a patient who clearly understands the toxicity and the limitation of the data, of course, for the physician. What is the optimal duration of CDK4/6 inhibition? Of course, one thing that it cannot be given for a very prolonged period. Thank you.
Thank you, Dr. Piyush. Can I please, and I think Dr. Priya Tiwari's talk is pre-recorded. Pooja, could you please play it?
Sure, ma'am.
Hello, everyone. We'll be discussing AI, that is aromatase inhibitors versus tamoxifen in premenopausal females with ER positive early stage breast cancer treated with ovarian suppression. Patient level meta-analysis of more than 7,000 women in 4 randomized trial. So as we understand, tamoxifen reduces 15-year breast cancer mortality by 1/3 in hormone receptor positive disease. Aromatase inhibitors are even more effective than tamoxifen in postmenopausal females. AI may benefit premenopausal women treated with ovarian suppression. So meta-analysis of the individual patient data for 4 trials of the premenopausal females with early stage breast cancer treated with OFS randomized to AI or tamoxifen. Primary outcomes were recurrences and the cause-specific mortality analyzed by the standard EBC TCG methods. So these are the list of the trial. There were actually 4 trials. The oldest one was SABCSHighlights trial, which started in the year 1999. Here, the goserelin and the anastrozole versus tamoxifen, the hormonal treatment was given for 3 years. And in the subsequent trials, it was for 5 years. All had randomized all had median follow-up period for more than 4 years. So what was important was not all the patients were given chemotherapy in these trials with SABCSHighlights. Only neoadjuvant was allowed, and around 5% patient took the treatment. TEX trial, again, it was optional concurrently with OFS, and around 60% patient took chemotherapy. In the SOFT trial, it was 54%, and in the HOBO trial before randomization, so around 63% patients. Now, when we compare the recurrences rates, we see that the tamoxifen arm had higher rate of recurrences compared to the AI arm. So overall 10-year gain was 2.8%. And if you compare, you find that yes, if you see the individual data, you see yes, the majority of the studies actually has favored AI arm. There is reasonable amount of heterogeneity between these trials. However, the p-value is only borderline. Now, the distant recurrence rate again was higher in the tamoxifen arm compared to the AI arm. But when you talk about the breast cancer mortality, and this is a very important figure, it was not much different in the tamoxifen versus AI arm. Authors do say that this might be because we still need for a longer follow-up. We understand for a hormone receptor positive breast cancer, for the treatment being given in the adjuvant setting, treatment, that there will be lesser number of events, especially death. So you require a longer follow-up. A subgroup analysis by any recurrence was done, and the 13 analysis investigating possible variability. Proportional reduction in the recurrences did not vary by age, BMI, tumor size, tumor grade, histological subtypes, or the presence absence of the chemotherapy. A very important finding, recurrences by the nodal status, and we do see a difference here. Now in N0 and N1 and lymph node N1 to 3, we see that the treatment AI is favorable. However, in N4 plus, which if we see in large number of patients, we see tamoxifen might be slightly better. So that is AI is. So this is something which has not been explained. So in N0, definitely the recurrence risk is higher with tamoxifen. In N1 and 2, 3, again, tamoxifen risk has higher recurrences risk. But it is not very clear why in N4 plus, this is not the case. We expect that if the drug is actually effective, as the risk score will increase, you expect the benefit to be maintained. We do understand that the AI affects bone health, and a higher number of bone fractures was seen in the AI arm in this particular meta-analysis. And yes, not much difference in the non-breast cancer death rates. So what the authors concluded that using AI rather than a tamoxifen in premenopausal females receiving OFS reduced the risk of breast cancer recurrences by 21%. Reduction in the distance recurrences, but no effect on the breast cancer mortality or overall survival. Longer follow-up is needed. No increase in the non-breast cancer death. However, more fractures in the women receiving AI. So despite overall findings from the meta-analysis, women with N4 plus disease did not derive benefit from AI. And as already said, that the risk reduction for N0 was 29%, 28% for N1, 2, and 3. This is highly unexplainable that why there should be increase in risk for the recurrence associated with N4 plus. There was another meta-analysis published in the Lancet 2015, which actually did not show any lesser benefit in N4 plus disease. So there's some discordance in the data here. Maybe with a longer follow-up, we'll find a better answer. The study markedly is relevant to the Indian setting as higher percentage of premenopausal females compared to the West. But what is important is that while giving AI, we have in the premenopausal females, we have to ensure that the adequate ovarian suppression is achieved, especially while using GnRH analogs. Thank you.
Thank you, ma'am. And next, I would like to invite Dr. Sajan Raj Purohit, Director, Department of Medical Oncology, BLK Super Specialty Hospital, Max Super Specialty Hospital, Delhi. And he's going to speak on randomized comparison of adjuvant aromatic inhibitor exemestase E plus ovarian function suppression. Over to you, sir.
Thank you, organizers. And can I have my presentation on from your side, ma'am?
Yeah, sure, ma'am. Sure, sir. Pooja or Garima, can you just show sir slides?
So meanwhile, the presentation is being loaded. I'm going to talk about next 5 to 7 minutes about I think the current analysis in 2021 of soft and text data, the median of 8 years follow-up. So let's have the presentation. So there are a lot of learnings from the 8-year data. We had a data at 5 years. Now we had 8 years. So okay. Can we go to the next slide, please? So this is the randomized comparison of the adjuvant ovarian function suppression versus tamoxifen and the data of the combined data analysis of soft and text. So the context is that these trials were launched in 2003 to answer 3 questions about the adjuvant therapy for premenopausal women with hormone-positive early breast cancer. The questions were, is there benefit from adding ovarian function suppression to tamoxifen, in particular for women who remain premenopausal after chemotherapy? When OFS is given, is there a benefit of aromatase inhibitor compared to tamoxifen? And when chemotherapy benefit is uncertain, if the maximum endocrine therapy of OFS, this OFS with oral endocrine therapy is planned, what is the derived benefit of adjuvant chemotherapy? So this the Perche trial was the Perche arm was closed early. So we'll be answering the first 2 questions with the first 2 research questions. Next slide. So the previous 5 and 8 years median follow-up had shown that addition of OFS to tamoxifen reduces recurrence and death, and further reduction of distance recurrence but not death with AI exemestane plus OFS versus tamoxifen plus OFS. Absolute benefit and varies depending upon the underlying risk of recurrence. Those with lower risk clinical pathological features fared really well with tamoxifen alone. And this was a planned update with a focus on distant recurrence and overall survival and later treatment benefits. So the median follow-up of the soft and text at this analysis, which was presented, was 12 and 13 years respectively, and 76% patients were alive and were in follow-up, and 92% were had the last visit in 2019 to 2020. Next slide. So we know the trial schema. So the text, which was a tamoxifen and exemestane trial, had 2 arms: tamoxifen plus ovarian function suppression for 5 years versus exemestane plus OFS for 5 years. And the second was the soft trial, which was suppression of ovarian function trial for. It had 3 arms: tamoxifen for 5 years, tamoxifen plus OFS for 5 years, and exemestane plus OFS for 5 years. The inclusion criteria were quite similar: premenopausal hormone positive patients with less than 12 weeks of surgery, and there was a planned ovarian function suppression in the form of either triploretin or oophorectomy. And the good thing was that there were two subsets. One was a patient who were really early, where the clinicians there were some criteria which we don't know, but there were certain patients, almost I would say 30% of patients in both the trials, which were not given any adjuvant chemotherapy. So 1053 in the text trial versus 1607 of chemo versus no chemo. Similarly, almost 1419 no chemo in the soft trial versus 1628 who received chemotherapy. So these were the inclusion patients, and the median follow-up was 13 years for text and 12 years for soft. Next slide. So these were the 2 questions which were answered. First was whether OFS benefited, and other was whether EFS versus only tamoxifen. Was there a subset which was good enough only with tamoxifen? Next slide. Next slide. So if we just see the patient characteristics here, so almost 21% of patients were less than 35 years in the soft, and around 16% of patients were less than 35 years in the text trial. Lymph node positive patients were almost, I would say, in the soft trial were in the tune of around 65% patients were lymph node positive, and around something around it will be around 66 to 68% patients were positive in the text trial. Tumor size more than 2 centimeters. Again, in the various whether chemo versus no chemo, there were other sub-stratifications. Roughly around 14% patients in the no chemo versus 47% in the chemo in the soft, and 19% versus 53% in the no chemo versus chemo in the text trial. Grade 3 tumors, 7% in the no chemo, 34% in the chemo in the soft trial, and 11% versus 37% in the text trial. HER2 patients were also allowed. So almost, I would say, 19% in the soft trial patients were in the chemo arm had HER2 positive. They were allowed in the soft trial, and also around similar number of patients were HER2 positive. And that point in time, I think it made a sense, because we didn't have so many agents for HER2 blockage, and these patients were put on the trial. They were part of the trial. And median time to randomization was almost around 1.5 months, and in the chemo, in the no chemo arm, and roughly around 8 months in the chemo and in the soft trial. Next slide.
My apologies, sir. You are left with 2 minutes to conclude your presentation. Thank you.
Okay. So I'll just rush through the important slides which are left. So distance recurrence-free survival. If we just compare exemestane to tamoxifen arms, we could see that the absolute reduction in distance recurrence was in the tamoxifen plus OFS versus only tamoxifen alone was 1.4% and 2.3% at 12 years. And also, this is very important data. So only compared to tamoxifen, the absolute reductions in distance recurrence, so this is very important. So compared to tamoxifen, exemestane plus OFS had absolute reduction of 3% in the distance recurrence and 2.6% in the death ratios at 12 years. Very important data, which is the finding at 12 years and 13 years in these arms. Next slide. So similarly, if we just compare between these two arms, whether exemestane or tamoxifen, absolute reduction in the exemestane was 1.8% higher at 12 years in the exemestane compared to tamoxifen arm, and the risk reduction death was only 1% at 12 years. Next slide, please. Also, if we just see in lymph node positive patients, the 95% of patients were surviving at 12 years. However, 56% of patients who had this event because of a recurrence, either local or distant. So there was a breast-related event which led to the distance-free survival event, which was related only to the breast cancer. Next slide. Similarly, 95% of patients were surviving at 12 years in all the lymph node positive. If we just compare the soft and the text data combined analysis, and 70% of the deaths occurred due to a breast cancer event. Next slide. Now, if we compare in the soft, if we compare tamoxifen plus ovarian suppression versus tamoxifen, absolute reduction in the distance recurrence was 2.6% at 12 years, and reduction death had 4.7% difference. So there was definite improvement in the deaths in the tamoxifen plus ovarian suppression at 12 years in the soft data, only compared to tamoxifen. Similarly, in the arm of exemestane, also there was a reduction in the tune of 4.5% in the distance recurrence, as well as 4% in the death rates at 12 years. So addition of OFS had both a statistically significant improvement in both the distance recurrence-free survival as well as an overall survival. Next slide. Especially in the subset of lymph node positive patients. Next slide. Next slide. Now, coming to this very important aspect, that in the subgroup of HER2 negative, because that was a subset, because almost around 15 to 20% of the in the both soft and text data was of the HER2 positive patients. So if we just exclude these patients, in the HER2 negative patients, exemestane plus ovarian suppression versus tamoxifen plus ovarian function suppression, absolute improvement was 3.3% at 12 years. Next slide. So if you just see the this forest plots, we could see that in patients in all subgroups, there was a benefit of using ovarian function suppression, whether it was the age of randomization, the lymph nodal status. The patients who had high grade had higher benefit, and in the patients who were low grade, low risk patients, even tamoxifen did better than I'd say it did slightly better than the ovarian function suppression. That might be enough for such patients who are low risk and with multiple characteristics being low risk for and who are not exposed to chemotherapy. Next slide. So the key messages were that distant recurrences and deaths from breast cancer continue to be occurring in patients with pre-menopausal hormone positive patients, and follow-up continued. This continued to happen beyond the first follow-up of 5 years. Meaningful relative reductions in the distant recurrences and death persist for use of ovarian function suppression with either of the endocrine therapy or versus tamoxifen alone, and requires appropriate selection of the patients for OFS. Absolute reductions at 12 years were more clinically substantial, almost 10% for those at higher clinical risk. So this was the key derivative. And for patients with low clinical risk, more than 95% of patients were surviving at 12 years with all the three treatments. So they might not benefit with chemotherapy or with additional ovarian function suppression. In fact, the derivative was that only 1% patient will benefit with OFS in such a patient to expose 99% of these patients. So that might not be meaningful for low clinical risk patients. Reduction in distant recurrence with exemestane plus OFS versus tamoxifen plus OFS was consistent with postmenopausal women and of substantial magnitude for those with higher risk. And emergent later survival benefit and improvement with the exemestane plus OFS occurred at 3.3% at 12 years for those patients who are HER2 negative breast cancer who had received chemotherapy. So these were the key takeaways of the 12 and 13 year analysis of soft and text. Next slide.
So you are left with just 1 minute
Thank you.
to conclude.
Thank you. Thank you, ma'am. Ma'am, you are on mute.
Thank you so much, Dr. Sajjan Rajpurohit, for elaborating on the text and the soft trial. And we come to the next important and interesting subject of view from the trenches. What will you do on a Monday morning? And I invite Dr. T. Raja, the senior most consultant and director of chemotherapy medical oncology at the Chennai Cancer Center. Dr. Raja, please take over the mic and invite your discussants.
Thank you, madam. Thank you so much for inviting me to be here. It's an excellent meeting. As usual, it's a great organized meeting. Thank you so much. Today we had some very good presentation from Dr. Sajjan and Priya and also Piyush. And I'm going to be joined by two very senior panelists, Dr. Minu Alia and Dr. Seema Gulia. And it's going to be a chat, probably I would say, rather than a moderation. It is just a roundtable chat. We're going to answer three important questions. One, is ovarian function suppression necessary for all premenopausal females? Number two, is aromatase inhibitors necessary for all premenopausal women? And thirdly, is CDK4/6 inhibitors already knocking the door in the adjuvant setting? Or whether all three have to be selectively chosen? That's the question we are going to ask here. And so the first question is benefits of ovarian suppression in the premenopausal breast cancer. And we saw the presentation. Dr. Reagan presented it in San Antonio, and here Dr. Sajjan. And the text and soft trial update, Raj Purohit presented this. And this is the essential conclusion he had. Meaningful relative reduction in the distant recurrence and death persists with the use of ovarian function suppression with either of the oral endocrine therapy options. That's the key word. And but then we may require appropriate selection. Absolute reduction at 12 year is more clinically substantial. That's around tune of 10%. For those with higher risk, for low clinical risk, 95% were surviving at 12 years with all the 3 treatments. The second point was reduction in the distant recurrences with the ovarian function suppression and the aromatase inhibitor, that is the exemestane, is consistent with what we see in the post-menopausal women. So that's what substantial magnitude equal to post-menopausal. That was the conclusion. So I would ask Dr. Meenu, what is your take on this conclusion, Dr. Meenu?
So basically, I feel, Dr. Raja, you yourself have given the final message. At the end of the day, we need to individualize the therapies, although we can have broader guidelines. But at the end of the day, the disease biology and how much are the risk factors, that is important. The data, the 12-year data from soft and text itself shows in the low risk population, more than 95% of these people are going to do well, irrespective of the hormonal agent, whether ovarian suppression is added or not. So at present also, what I feel is what we need to be doing is ovarian suppression plus AI should be reserved for the high risk category. A very low risk category, a strongly hormone receptor positive, HER2 negative patient, a very low risk disease, I will not be very keen to add ovarian suppression.
We'll come to that. Thank you, Dr. Meenu. Dr. Seema, your quick take on this conclusions on the soft and text updates.
Yes, so definitely we do not need either ovarian suppression or AI for all patients. We need to modulate our therapy based on the clinical factors. One more point which I would like to add here is that both soft and text trial were based on the clinico-pathological factors. None of the genomic factors were taken in consideration while planning either ovarian suppression or AI. So based on the clinico-pathological factors which are readily available to us in clinic, we can very well separate patients who need ovarian suppression versus those who don't.
Okay, so this is how the soft trial was originally, and the soft and text. You would see that there were some subtle differences. When ovarian function suppression was added in the soft trial and when the ovarian function suppression was added in the text trial, and the 3-armed versus 2-armed. So that's not a problem. But then there are some, so here is one of the criticism. The formal criteria to define high risk was not really present originally as a thought process. Was it an afterthought? And high risk includes all these patients, etc. Essentially, these are the patients who receive chemotherapy, age, etc., etc. So, Dr. Seema, to you, is this a statistical manipulation?
I mean, if I have understood your question correctly, so statistical manipulation in terms of defining the risk factors.
Yes.
So not really, because there is also another trial, which is E142 trial, which randomized patient between tamoxifen alone versus tamoxifen plus ovarian function suppression. And this trial included patient who had 0 to 3 centimeter of tumor size and node negative. And that trial also did not find any difference in either recurrence rate or overall survival with the addition of ovarian function suppression over and above tamoxifen. So really the low risk group does not benefit by adding ovarian function suppression, and similarly by addition of AI. And that data we can get from the SABCSHighlights trial, where the anastrozole versus tamoxifen, the tamoxifen arm was slightly better than AI arm, because in that trial majority of the patients were low risk compared to other trials which incorporated AI in premenopausal patient women, where majority of them were high risk. So it is not a statistical manipulation. It is basically the biology of the disease and the tumor size and nodal status at presentation that define their outcome.
Fair enough. Very well answered. Thank you so much. Dr. Meenu, do you have, this is the 12-year update of these 2 trials put together. And the essentials of it is that the distant metastasis-free survival was 88.4% with the AI plus OFS and 86.6% with tamoxifen OFS. The difference was a relative 17% reduction in the hazard ratio in favor of AI plus the OFS. The overall survival was 90 and 89, so not still significant. And in low-risk patients, the 12-year overall survival was 95% on all the strategy. If it is a 3-arm in the soft or 2-arm in the text, it's all the same. And the absolute reductions are more substantial for the higher risk, on the order of 10% reduction in the death, emphasizing appropriate selection. So tomorrow on Monday, should that be a patient T, node, and so on and so forth, what will be a selection criteria?
So again, if it is a high risk case, premenopausal lady, hormone receptor positive, high nodal burden, high risk case, grade 3 disease, possibly I will definitely go for OFS plus AI. However, if the same lady with a low risk biology, probably a small tumor, T1C, a grade 1 tumor, no lymph nodes, then I don't think there is an added advantage. We already have data and an added advantage of adding either OFS or even changing over to AIs.
Fine. So the combined analysis shows this. There is a 12-year DFS benefit and a 12-year invasive invasive breast cancer free interval benefit, and there is a 12-year distance recurrence free interval. I mean, it is understood that in endocrine disease, 10-year is something and 20-year is also something. 12-year is quite a good number, I would say. Why is that there is no overall survival advantage despite having a magnitude of 10% or 17% hazard ratio reduction at all? So this is the combined analysis that says that at at a difference of 1.8% absolute difference in 12-year distant metastasis free survival, it was statistically significant. The 1-year absolute difference at 12-year for overall survival was not statistically different. So overall survival, so what would you take it as, Dr. Meenu, to you?
I feel it is like this is a group of patients where we will be having longer survivors. So possibly the OS benefit is yet to be seen. So it may be early, even 12 years. 12 years, well, may not be very early for a triple negative or a HUP or a HER2 positive. But for this subgroup of patients, maybe we also find an OS advantage in the longer follow-up. So 12 years may be early in this subset of patient.
Longer follow-up is what will you hazard risk as 20-year? Would you say that? Or?
So in many of our studies, we have seen that even at follow-up at 20, we are seeing benefits after 18 years, after 20 years, 25 years also. So to have a conclusive evidence at this level, and at 12 years, there is no OS advantage, I might say that it is probably premature. We should wait longer.
Here is the conclusion and the kind of criticism on this, that ovarian function suppression is a clear winner in premenopausal. There is no overall survival benefit yet to be seen, but this is highly restricted to high-risk individual. Of course, tolerability is an issue with this function suppression. There are a couple of questions that are asked in this. These are premenopausal females. Some of them may be still looking at fertility. How do we address that? And then there is one other vexing question that we have seen, that aromatase inhibitors in the postmenopausal, 5 years probably is not enough, probably 7 years and so on and so forth has been well shown now. So how do I take this data in premenopausal? OFS is 5-year in inferior attitude. How do I do that, Dr. Seema? How do you answer these two questions? The duration of endocrine therapy, having invented the OFS, and how do I apply my knowledge that a longer therapy is better in the postmenopausal, and then fertility issues, Dr. Seema?
So till date, we have evidence for ovarian function suppression, which is given up to 5 years based on the soft and text trial. More than 5 years giving ovarian suppression, the data is not there, and therefore we cannot apply this in routine clinical practice. Regarding the question of overall survival, I think 12 year is a long enough follow-up data to suggest that. And we have seen clearly that at least in premenopausal patients, if we look at all the curves and the number of deaths that are happening with AI versus the tamoxifen, the deaths are either more in the AI arm or they are similar. So there is no OS benefit. So why is this happening? It could be because of the tolerability issue. Even in the soft and text trial, 19% of the patient did not achieve menopause with ovarian function suppression. So that might be the reason why we did not see the OS benefit in spite of ovarian, in spite of differences seen in the distant as well as the recurrences which is seen in these patients.
Okay, and for want of time, I'm quickly just looking at this specific question of aromatase inhibitors per se versus tamoxifen. And, let's look at that critically. Conclusion was that, AI rather than tamoxifen in premenopausal reduces the risk of breast cancer recurrence by 21% and 17%. So your take, Dr. Meenu, on this.
Can we come again?
The AI, just the AI question. Leave the OFS. OFS is already there. So once you have selected OFS, so should it always be an AI or a tamoxifen? That's the next question I want to ask.
So again, it is not always AI. It can be tamoxifen also, provided depending on the patient risk factors. But if it is a high risk disease, then the preference will be an AI plus OFS.
Okay, here is a data set that was published, this year. This is by Dr. Dacus, and they have looked at more than 2,000 patients in whom adjuvant aromatase inhibitors or tamoxifen, but following chemotherapy, assuming that this would be a high-risk patient, so on and so forth, premenopausal. So what do they see is this: the recurrence-free interval is much better whenever there is an AI, at least 25% of the distance of the endocrine therapy. That's much better in the recurrence-free interval and also in the overall survival interval. So the indirect take of this particular paper is that more than 2,000 patients, that if you have chemotherapy on the board, that means if you have high-risk patient, AI is superior to tamoxifen. That's the dogmatic statement they have made. Dr. Seema, do you agree or you don't agree?
See, in postmenopausal, we can say that AI is superior to tamoxifen in terms of overall survival, but not in the premenopausal.
We are talking only about premenopausal. This is the discussion here.
Okay.
Okay. Anyway, there is another paper. This was a limited meta-analysis by Meng, published last year, but he took 3 of the 4 trials that was discussed by the presenter, and he shows that there is absolutely no difference between AA or tamoxifen in distance-free survival overall. But it's meta-analysis. This is a meta-analysis that was limited to 3 papers. So I leave the controversy there, and we'll move on to the last part of the Palace trial really made a lot of people turn their head. So coming to that, somebody is enthusiastically talking. Yeah, thank you. This is the Palace trial. The essential takeaway of that is that the palbociclib did not prolong the IDFS and no new toxicities were observed. But if you look at the Palace trial, it had a good number of premenopausal females, 53%. In Monarchy, 43%. And the problem was that adjuvant palbociclib for 2 years, no subset benefited. Even high-risk people did not benefit. Unlike in Monarchy, we're going to talk about it in a while. So
my apologies, the discussion is going well, but we need to have control on time.
I have to control the time, and I have only 2 more minutes.
2 more minutes. Thank you, sir. Thank you so much.
Yeah, absolutely. Dr. Meenu, so your take on Palace trial?
Basically after Palace, yes, we are not using we will not be using palbociclib in the adjuvant setting. The main question that always comes is that why the results from Palace and Monarchy are different. So maybe as already I think Sajjan very rightly pointed out, are we talking of 2 different molecules? That is still yet to be seen. Or is it the intermittent dosing or continuous dosing that has got something to do? And then again, it comes to possibly two different patient population. Yes, agreed that even in the high risk, it did not show benefit, but probably the trial was not powered for that. The population in the palace was moderate to high risk, and in the monarch was mainly high risk, comparatively a slightly higher risk population. So these are the 3-4 things that actually leave us to ponder that why the results are different from palace and monarchy. So in today's date, I don't see any role of definitely adjuvant palbociclib. But in a high risk case, with whatever data I have,
I think you have touched the most important point. If you look at the eligibility of palace, these are the one. And if I take you to the inclusion criteria of the monarchy, it has specifically looked at high risk patients. So that was the explanation, and it also had a good number of these were the conclusions. But then my question is, we are now enthusiastically looking at both the palace and the monarchy, and the Australian is used what happened between those two trials. So my question to Dr. Seema is this. Is this because the molecule is different? Is this because the population was different and scheduling, so on and so forth? What's the explanation for the apparent success of monarchy and the failure of palace, Dr. Seema?
Yeah, I think the most important reason is the drug and the intermittent scheduling, which made the difference between the palace and the monarchy trial. And we have seen that if we can take an example from triple negative breast cancer, the immunotherapy behave differently in adjuvant setting versus metastatic setting. Maybe similar is the case with the CDK4/6 inhibitor in adjuvant setting versus the metastatic setting. So these molecules do behave differently in adjuvant setting. The reasons are still unclear. But given the most important reason, I think, is the continuous scheduling of abemaciclib that made the difference.
Thank you, Dr. Seema. My last question to Dr. Meenu. So Monday, would you want to take forward abemaciclib for the adjuvant setting? And if so, for which patients, Dr. Meenu? That will be my last question. With that, I thank the organizers.
Very high risk, young patient. Yes, in today's date, I will consider abemaciclib.
What is your very high risk population, Dr.?
Something like we do find patients like yesterday only I saw a patient 25 by 28 lymph nodes positive, grade 3 disease, a young female, maybe, I mean, hormone receptor positive, of course, in that subgroup we are talking of. So this is a case I know that she will ultimately she's going to relapse anyway. So in today's date, I will just consider abemaciclib.
Thank you. Thank you for your answer. And to the organizers, over to you. Thank you so much for entertaining.
Thank you for the excellent discussion, sir. And next we move on to, for this, I would like to invite our chairperson, Dr. D.C. Doval, who is Chief Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, and Dr. Arun Goyal, Senior Director, Oncology, Breast Cancer, Surgical Oncology, Max Healthcare, Delhi. Over to you, sir, to invite further the speakers, moderator, and discussant.
Good evening to you all, and now we have the topics for this session are the role of genomic assays in HR positive early breast cancer. A very interesting topic, and I think lots of things are moving towards the well-defined use of hormonal treatment in various patient groups. And I'll invite now Dr. Ramesh Sareen, who will be talking on updated results from a phase 3 randomized clinical trial in participants with 1 to 3 positive nodes, hormone receptor positive, HER2 negative, breast cancer with recurrence for 25 randomized endocrine therapy or chemotherapy, SWOG XS1007 RX Ponder study. Dr. Ramesh Sareen, please.
Hello. Aram, can you please project my slides? I'm just finding it a little difficult here.
Pooja, can you do that? Ma'am, you need to stop sharing first.
Thank you, organizers, for allowing me to present this updated results of responder trial. The responder trial, as we all know, was designed to predict chemotherapy benefit in hormone receptor positive, node positive breast cancer patient based on 21 gene assay, so-called the Oncotype DX recurrence score test. The chemotherapy benefit in node-negative patients, both in postmenopausal and in premenopausal, have been alluded to earlier on. That was my disclosure. This slide shows you that the early breast cancer trialist or collaborative group meta-analysis of randomized studies of trials with and without chemotherapy shows that no more than 10% of the patients, node negative or node positive, derive chemotherapy benefit, which means that 90% of them do not have a benefit with chemotherapy. The next study, the next slide shows that SWOG 8814 trial in node positive postmenopausal women with 367 patients were randomized to chemotherapy versus no chemotherapy, and the slides and the blocks of these patients was retrospectively sent for the Oncotype DX, the gene assay, the 21 gene test. And it showed that women with low recurrence score of 0 to 17 on the left side showed no benefit in the group receiving chemotherapy followed by endocrine therapy versus those who are receiving only endocrine therapy. On the right, if you see the recurrence score results of 31 to 100 showed benefit from the chemotherapy to the tune of 20%. The intermediate score of 18 to 30 had not a very straight answer, and this was the reason to refine it further that the responder trial was designed. The next slide. The SWOG 884 was tested. Had tested the hypothesis that in this postmenopausal population, the absolute risk of recurrence increases with the higher recurrence score. As you can see, the higher recurrence score has the higher, as the recurrence increases, the Oncotype DX score also rises. So the Oncotype DX is both prognostic as well as predictive of chemotherapy. And this was the basis for refining and for starting the responder trial. The next slide. The responder trial was randomized in women more than 18 years of age with node positive, 1 to 3 nodes, hormone receptor positive, HER2 negative, non-metastatic breast cancer patients. All these patients had the Oncotype DX 21 gene assays done. Anybody with an Oncotype DX recurrence score of 25 and above, 26 and above were taken off the study and recommended chemotherapy followed by endocrine therapy. Scores from 0 to 25 patients were randomized to receive endocrine therapy alone or to chemoendocrine therapy. The stratification factors, as you see on the left, were recurrence score of 0 to 13 versus 14 to 25, menopausal status pre versus postmenopausal, and nodal surgery, axillary lymph node dissection versus the sentinel lymph node dissection. These were the stratification factors. The next slide. A retrospective block or unstained slice of the primary tumor, as we said, was sent to the genomic health and the recurrence score was obtained. The primary objective of the analysis was to assess the effect of chemotherapy on the invasive disease-free survival, which were a very strict criteria of death from breast cancer, death from any other cancer or unknown causes, and loco-regional recurrence or distant recurrence. The distant relapse-free survival included deaths from breast cancer or from other causes and distant recurrence. A third endpoint evaluation was added in this year's presentation, which was distance recurrence-free interval, which included patients dying from breast cancer or having distant recurrences. An evaluation point which is more amenable to our patients and for further prognosis, for long-term prognosis. The next slide shows that all the characteristics of the patients in the two arms of chemoendocrine therapy versus the endocrine therapy matched with regard to the menopausal status, positive nodes, nodal dissection, and the other parameters. If you can notice that in the menopausal status, 75% of the patients, or more than 2/3 of the patients, were postmenopausal and 1/3 premenopausal. The lymph nodes positive were 1 to 2 lymph nodes positive happened in more than 80% of the patients. But both the arms were very well matched. The next slide shows that the results in the post-menopausal women with 1 to 3 positive lymph nodes and a recurrence score of 0 to 25, that there was no chemotherapy benefit in the updated analysis presented this year at San Antonio with 6.1 years of median follow-up. Whether it was invasive disease-free survival or whether it was distant relapse-free survival, there was no benefit of adding chemotherapy to such patients. The next slide. The third endpoint, next slide. The third endpoint, which has been added this year, of distance recurrence-free survival, more applicable to the patients for the longer follow-up, also showed no statistical significant difference in recurrence-free recurrence interval of 4.2 versus 3.4% randomization. The next slide shows that all subgroup of patients in this postmenopausal who received chemotherapy versus who did not receive chemotherapy did not benefit. All subgroup of patients, whether it was age, grade, tumor size, clinical risk, nodes, did not benefit from the addition of chemotherapy. The next slide. We come to the next slide. When you categorize or subdivide these patients of a recurrence score 0 to 13 versus 14 to 25, both the recurrence score group of patients did not benefit from the addition of chemotherapy in this, again, set of patients which are postmenopausal and node 1 to 3 positive. The next slide shows that whether it was 1 lymph node positive or 2 to 3 lymph nodes positive, there was no difference with the addition of chemotherapy. The next slide, we come to the premenopausal women. The premenopausal women with nodal N1 disease, 1 to 3 lymph nodes positive, and score of 0 to 25 showed a benefit from the addition of chemotherapy in the recently updated analysis of 6.1 years, which was also the same in the last year presentation of 5.1 years of median follow-up. The invasive disease-free survival advantage was 4.9%. with a p-value of p004, and also the distance relapse-free survival showed absolute benefit in the distance relapse-free survival of 2.5% with a p-value of 0.033. The next slide shows that all the recently added evaluation point of distance recurrence-free interval, more applicable, also shows a benefit of adding chemotherapy in these premenopausal women, and the absolute difference was 2.4%. The next slide, all these subset of patients, whether it was whatever the age, grade, or tumor size, benefited from the addition of chemotherapy, and the absolute value was 2.3 to 2.8%. The next slide, again, when we categorize them to recurrence score of 0 to 13 or 14 to 25, even the 0 to 13 subgroup of 21 gene SA patients showed an absolute benefit of addition of chemotherapy to the tune of 3.9% as against the higher risk of 14 to 25 or 5.8%. The next slide shows the model that has been designed from this. It shows that as the recurrence score is going up, the chemotherapy benefit continues, and possibly it's a larger benefit as the recurrence score goes up. The next slide shows that there was the slide before. In addition, the previous slide. In addition to the presentation of benefit in postmenopausal, no benefit in postmenopausal women and benefit in premenopausal women with node positivity, they did 3 more subgroup analysis, the post hoc analysis in premenopausal women only. The women who had micrometastases, did they do better with chemotherapy versus the macrometastasis? And these are the results. If you can see on the left side, the women with micromets also benefited to the tune of 7.3% versus those who only had endocrine therapy. But please note the number of patients were very few, 206, and the number of invasive disease-free events were only 22, and the randomization of this micromets patients was stopped in 2014 because they thought that a large number of micromets patients were being randomized. So you have to take this in consideration. While in occult metastases, as we already seen, that there is an absolute benefit of chemotherapy to the tune of 4.8%. The next slide shows that the what was the effect of ovarian function suppression treatment in these premenopausal women? If we suppress their ovaries, do they do better with chemotherapy or they do better with endocrine therapy? If you can see on the left side that 16% of the patients had the ovarian function suppression in the endocrine arm in the first 6 months versus only 3% in the chemoendocrine arm. The ovarian function suppression was increased as the time increased, and in both the subsets, the ovarian function treatment suppression was low, but it remained consistent. When they compared this group of ovarian function suppression versus no ovarian function suppression, there was no difference in women who received the ovarian function suppression versus those who did not have the ovarian function suppression in the first 24 months. As you can realize, as I said, that this is a post hoc analysis of 2 years, and there are a number of confounding factors. The next slide shows the next slide, they actually assessed what was the number of patients who stopped having regular periods or who continued to have regular periods. As expected, in the endocrine arm, 50% of the patients continue to have the regular periods versus 25% of the women in the chemoendocrine arm who had the regular periods only. 75% of them did not have the regular periods as expected. Though the number of the endocrine therapy arm, the rate of regular periods decreased in both the arms, but it was higher in the chemo arm. The results of this next slide show that the next slide shows that those who had the endocrine therapy alone and where the period stopped did better than the women where the periods did not stop. And similar was the result in the chemoendocrine arm where the period stopped. These women did better than the one where the periods did not stop. This was a numerical improvement in the invasive disease-free survival in these premenopausal women of groups, but statistically it was not significant. The next slide is showing the conclusions of this updated analysis of responder trial presented at this year's San Antonio that majority of the N1 postmenopausal women can now be spared chemotherapy based on the recurrence score result of 0 to 25, and this is independent of clinico-pathological parameters. This was the updated results, which was the same as the last year's results. In the premenopausal women with node positive, the recurrence score results of 0 to 25 had a 2.4% absolute benefit from chemotherapy based on 5-year distance recurrence-free interval. The 3 subset analysis that the responder group did was, it was not powered for this subgroup and differences, and the data interpretation can be challenging. What I told you about the micromets and the women having ovarian function suppression and those not having their periods, because the confounding factors change over time. The responder trial has further refined the findings of the SWOG 8814, which established that 21 gene assay was predictive of chemotherapy benefit in node-positive postmenopausal patients. The next slide. When you put the whole perspectives into this slide, you can see that women who were postmenopausal and more than 50 years, whether they are node negative or node positive, there is no chemotherapy benefit with the recurrence score of 0 to 25, but there is a substantial chemotherapy benefit beyond 25. In the premenopausal women, you see the last line that there is node positive patients, there is a chemotherapy benefit of 2.3% when the recurrence score is 0 to 13 versus 2.8% when the recurrence score is 14 to 25. And from the Taylor X trial, we know about the node negative patients premenopausal. The next slide. When you come to the real world data, more than 80% of the patients, whether it's Sears registry or CLALET registry or the global clinical laboratory outcome, more than 80% of the patients would belong to scores of 0 to 25. And these patients, in these patients, the postmenopausal women can be spared the chemotherapy. And as you saw that 75% of the patients recruited in the trial were postmenopausal. So 75% of this more than 80% people can be spared the chemotherapy, chemotherapy treatment when they have node positivity. So this one is an important important biomarker, or you can say important gene test to suggest whether a patient in the postmenopausal women should have the chemotherapy or not. And thank you so much for listening to me. And I would now invite Dr. Advani to give his balanced remarks as to what he would do on a Monday morning if he had a patient who was postmenopausal and had lymph nodes, and if he had a patient with premenopausal and lymph node involvement. Dr. Advani, please.
Yeah. Good evening. First of all, I'm thankful to the organizers for giving me this opportunity to speak, on which Dr. Sarin has already expressed the full detailed view. I would like to mention that in the postmenopausal females with hormone positive and HER2 negative, the benefits of chemotherapy are absolutely limited, while in the premenopausal there's a definite some benefit, although very small, but it is there. And therefore, in the premenopausal females, the use of chemotherapy can be essential. However, I must say that the always a point comes, because obviously the breast cancer is common between 45 and 55. Commonest age, majority of the patients are at this age, and you don't know how to label them premenopausal and postmenopausal. Sometimes it's very difficult, particularly if they have just stopped menstruating maybe a year ago. And therefore, it is sometimes very difficult. Also, the effect of oophorectomy at this age, whenever you feel that the patient is just on the verge of going into the menopause, whether we should do the oophorectomy, make the patient postmenopausal, and then continue the treatment as postmenopausal females in terms of the score of Oncotype DX. Now that data is yet to come in. That whether we can convert a premenopausal female into a postmenopausal and then follow the postmenopausal score. Whether that will be valid or not, it's very difficult to say. But I think the things are otherwise clear that postmenopausal biologically, the tumor is different, responds much better to the hormone therapy, and therefore within the score of 25, there's no benefit from adjuvant chemotherapy. However, in premenopausal, where biology is totally different, that they will the adjuvant chemotherapy will certainly benefit to some extent. Thank you very much.
Thank
Thank
you,
you, sir.
Thank you. Go ahead.
Our next talk, I believe, is a pre-recorded one. So the presentation is by Dr. Tejinder Singh, who is a medical oncologist from Apollo Hospitals, Mumbai. And he's going to discuss the results of the Alliance trial A11106, which studied PALM50 intrinsic subtype and risk for recurrence score for prediction of endocrine sensitivity and pathologic response to chemotherapy in postmenopausal women who had stage 2 or 3 ER positive and HER2 negative breast cancer. Can we have the talk?
Everyone, thank you to the organizers for giving me the opportunity to present this abstract, which was presented in SABC. It's basically a PAM50 intrinsic subtype and ROR, we call risk of recurrence score for the prediction of endocrine sensitivity and pathological response to chemotherapy in a postmenopausal woman with stage 2 or stage 3 in a ER positive HER2 negative breast cancer. So this is basically a study which is also known as Alliance study and also known as alternate trial, in which they have done further testing by using a testing modality. So to give a background for this study, the study was basically to look at the role of neoadjuvant endocrine therapy. We know that basically neoadjuvant endocrine therapy, also called NET, is basically giving an opportunity to assess the endocrine therapy sensitivity for this particular group of patients. And they have also, in the alternate study, they had evaluated the Ki-67, and they found that the patients who have more than 10% Ki-67 on biopsy, after 2 to 4 weeks of NET, identifies the patient with those patients who are having intrinsic endocrine therapy resistance. There were 2 other things they gave a lot of importance. One was a pathological CR, and another is called MAPI. So MAPI is nothing but modified preoperative endocrine prognostic index, and this was calculated based on the T staging, that is T1 to 2, no nodes, and Ki-67 less than 2.7. They were categorized as MP 0 or more. So those patients who have modified preoperative endocrine prognostic score of 0, they were patients who had T1 and 2. They had N0 nodes and Ki67 of less than 2.7. So the reason
what happened to the presentation, please?
Ekta. Ekta.
Ma'am, they are saying recording again because we were not able to see the slides. Only face was visible.
Maybe he has no slides. Dr. Tejinder, you have no slide?
Dr. Tejinder is not here, it's recorded.
Response to chemotherapy in a postmenopausal woman with stage 2 or stage 3 in a ER positive HER2 negative breast cancer. So this is basically a study which is also known as alliance study and also known as alternate trial, in which they have done further testing by using a testing modality. So to give a background for endocrine therapy at week 4 and optional at week 12. So patients who were, like I said, patients who were more than Ki67 more than 10% at week 4 or 12 discontinued this particular therapy, and they were offered adjuvant chemotherapy. So this is the method and the study population. They had taken around 749 of the nearly 1300 eligible patients, and nearly 550 patients were excluded due to insufficient tumor for the RNA sequencing or the PAM50 normal subtype. So the study population was similar to the entire alternate population in regards to the rates of Ki67 at 4 or 12 weeks, and also at the basically they looked at the MAPI also, modified preoperative score. So of the nearly 700 patients which are included in the study, nearly 52% had the luminal A, 40% had luminal B, and basically 7% nearly had non-luminal type, and nearly 93 patients were switched to the neoadjuvant chemotherapy. So this is a study population looking at the baseline characteristic, and majority of the patient of luminal A or ROR low tumors were in the low grade, and they were basically having Ki67 less than 10%. And non-luminal breast cancer were mostly grade 3, and they have a high level of Ki67. More than nearly 26% had a Ki67 more than 50%. But important thing to remember is that nearly basically non-luminal tumor were not uniformly high grade. They were with the high Ki67. Since 39 or 40% were grade 1 or 2, and 28% had basically Ki67 and less than 1. So this is a sensitivity looking at the pathological CR post chemotherapy. You can see in luminal A it was just 0%, but in a HER2 enriched basically it was 21%, and luminal B it was 6.1%. Looking at the category ROR, the one which are having a high category, they had more pathological CR. So this is an important chart to look at the role of sensitivity to neoadjuvant endocrine therapy, and you can see certain points here that Ki67 more than 10% at week 4 or 12 on this NET or NEP0 or pathological CR status surgery post NET differed significantly with respect to the PAM50 subtype or RORP type. And PAM50 non-luminal types or high SUR were more likely to have an early chance that they will have a, you can see here the non-luminal, they have a rates of Ki67 was 71%. So basically these are the patients who are more likely to have an endocrine resistance. So the study concluded with certain points that they found that the non-luminal subtype was observed in nearly 7% of the alternate trial, despite a high ER expression at diagnosis. And non-luminal tumors were not uniformly high grade or with high Ki67. Ki67 more than 10% at week 4 and 12 on NET or this particular score at surgery post NET differs significantly to respect to the PAM50 subtype or RORP category. So there was a type we call non-luminous subtype or high RR. They were more likely to have a early on NET of more than 10%, indicating resistance to NET. So the patient who were triaged to neoadjuvant chemotherapy based on an early NET Ki67 more than 10%, the HER2 group had the highest pathological CR, and there was no pathological CR was observed in the luminal A type. So this basically study shows that this particular PAM50 subtype could be used to guide the neoadjuvant treatment decision in postmenopausal patients with ER positive HER2 negative breast cancer. So my take, basically, it's a very confusing study, honestly. We are still trying to find a place where we can utilize the neoadjuvant endocrine therapy in our setting, especially our Indian patients are different. So still a long way to make it an ideal test for decision on NET, apart from the histopath, which becomes very easy. But the PAM50 is one more method, but it's not so easy, cost effectiveness. And different labs have got different Ki67 scores. So the standardization of Ki67 is an issue. So we still require more studies to really give an answer to whether this particular PAM50 subtype, which patients are going to have a response to endocrine therapy or not. So long way, a bit confusing study with so much of ROR and other things. But I think future might hold that as we are going for the sequencing, that these things can be part of the decision making for patients who are on neoadjuvant endocrine therapy. Thank you. Thank you, everyone.
Since Dr. Tejinder is not here, we will move straight to the next presentation, which is by Dr. Krupa Shankar, who is a consultant medical oncologist and CanCure Center in Coimbatore. He is going to present or discuss the results of CCTGMA.32 trial, which is a phase 3 randomized trial, placebo-controlled, comparing metformin versus placebo as an adjuvant in early breast cancer. Dr. Krupa Shankar, please.
Thank you. I'll just share my screen and we'll get started, sir. Thank you. Well, hope my slides are visible and I'm audible.
Yes, sir.
Thank you. So very good evening to everyone. And at the outset, before I begin, I'd like to take this opportunity to congratulate the organizers and also thank them for the opportunity. So today I'm going to briefly be discussing on the Canadian Cancer Trial Group, the CCTG MA32 study, which was a randomization between metformin versus placebo on the risk of recurrence and survival in early stage breast cancer. So background, just a quick background about the study. Obesity, we all know, is associated with an increased risk of poor outcomes as far as breast cancer is concerned. And insulin levels are higher in obesity, and that's been actually strongly associated with the outcomes in breast cancer. So metformin was selected for this study because it does promote modest weight loss and lowers insulin by around 15 to 20%, even in non-diabetic survivors of breast cancer. And what we've seen in neoadjuvant studies based on window of opportunity trial designs is that it has also been shown to reduce the proliferative index of the Ki67 in the breast cancer cells. So based on in vitro and in vivo data, it has been shown to delay the growth of breast cancer cells as well. And that was the rationale for using metformin in these studies. That's based on a lot of observational studies done prior to this study. And we all know that metformin has become a standard of care as far as treating patients with diabetes who have breast cancer as well. And that's been associated with better outcomes as far as breast cancer is concerned as well. And metformin is a very inexpensive, well-tolerated generic drug that's easily available across the globe. So let's look briefly at the mechanism of action of metformin as far as using it as a neoplastic agent is concerned. We all know about its action on insulin resistance, where it cuts down on the gluconeogenesis, thereby creating a role in the circulating insulin levels. But how does it impact on this cancer cell signaling pathway? So the AMPK signaling, or the adenosine monophosphate protein kinase C signaling pathway, which actually inhibits the PI3K-AKT-mTOR pathway as well. So thereby the downstream signaling pathways get inhibited, and that has a major role to play as far as cell growth, proliferation, and translation is concerned. So that's how metformin has got antineoplastic properties as well. So the primary objectives of the MA32 study were to look at comparing the invasive disease-free survival between metformin compared to placebo for 5 years. And the secondary objectives were, of course, the other breast cancer outcomes like overall survival, distant disease-free survival, breast cancer-free interval, and breast cancer-specific mortality and contralateral breast cancer. And they did look at the health-related quality of life based on the URTC quality of life questionnaire as well. So just a brief look at the study design. They did include patients from 18 to 75 years of age, from T1 to T3 and N0 to 3, and they included both ER/PR positive and HER2 positive patients as well, and they were stratified based on their receptor status and also based on the HER2 positivity. And the randomization was again between metformin and placebo for up to 5 years. So these are the key results from the 3 subgroups that were actually looked at: in the ER/PR positive subset, the ER/PR negative subset, and the HER2 positive subset. So in the ER/PR positive subset, as far as the baseline characteristics were concerned, they were pretty evenly matched between metformin and the placebo, as you can see here. And well, what did we see here? Well, as far as the outcomes of IDFS or invasive disease-free survival, OS or distant DFS, breast cancer-free interval, and the breast cancer-free survival was concerned, well, you can clearly see that the hazard ratios were absolutely not significant with a non-significant p-value as well, hence negative in that subset. And that was the conclusion in the ER/PR positive subset as well, which made the authors conclude that metformin definitely has got no role as far as the treatment of breast cancer in this particular population or in the ER/PR positive subset. Well, what about in the ER/PR negative subset? Well, this, I must tell you, where they did a second interim analysis looking at patients who are ER/PR negative, and well, this was censored, and the IMDC actually recommended stopping because of futility in this particular subset, the ER/PR negative subset. Well, you can see that the curves are absolutely hugging each other, absolutely inseparable together. So no improvement in the IDFS or in the overall survival with the addition of metformin as compared to placebo. So again, the conclusions, the author's conclusions in the ER/PR negative subset as well, absolutely not to be used in this subset. Well, again, they looked at an exploratory analysis in the HER2 positive subset, and that actually turned out to be pretty interesting, and I'll show you the results from that. So again, they looked at the HER2 positive subset because there's been a study called the METEN study where they looked at 24 weeks of neoadjuvant metformin in combination along with trastuzumab for about 6 months. And interestingly enough, in those subset of patients who were randomized to metformin in that neoadjuvant study, so people who had a particular genotype with the C allele of a pre-specified ATM-associated single nucleotide polymorphism actually had a higher pathological CR rates as opposed to people who did not have that specific genotype. So hence they looked at the particular single nucleotide polymorphism, which bears a close resemblance to the ATM gene. And that has also been associated with the AMPK dependent and independent differential expression on a lot of genes. And that's also been shown to be associated with the benefit of metformin in glucose control in diabetes. So when we look at the HER2 positive
My
subset,
apologies, sir. You are just left with 1 minute to conclude your presentation. Thank you.
Thank you. So, well, as far as the HER2 positive subset, well, you can see here that again, 99% or about 97% went on to receive both trastuzumab and chemotherapy as well. So around 70% had the C subtype allele or the specific genotype. So again, interestingly enough, there was a benefit as far as IDFS was concerned, which was statistically significant. But remind you that this is only an exploratory subgroup analysis, and albeit a pre-specified one. But still, was it adequately powered enough to answer that question? And probably the benefit was driven primarily by patients, around 70% of patients who had the C subtype of allele or that particular genotype. And this is just to illustrate the same point that patients with the C type allele actually were the ones who seem to benefit the most, and that the benefit was primarily driven by that subset. So again, to conclude, this probably requires replication in a prospective trial, and you can't take home much based on just an exploratory pre-specified subgroup analysis. So to conclude, I would say metformin absolutely did not improve on the primary endpoint of the study, which was the IDFS, nor on the other secondary outcomes as well in any high-risk ER/PR positive or negative subsets, and hence should not be considered as standard of care in those population. And because diabetic patients were not included in the study, well, the use of metformin should not be extrapolated to treat diabetes in patients with breast cancer. And exploratory analysis, well, again, just seemed to show that there was a beneficial effect, at least in patients with the particular genotype of C allele. But those observations absolutely have to be replicated in future research. So with that, I'm going to thank you all and say thank you for your patient listening.
Thank you, Dr. Kripa, for finishing fast. And now we'll move straight on to the all-important section of what we will be doing on Monday morning. Dear friend, Dr. Nitesh is going to moderate, and I would ask Dr. Nitesh to take over and invite the
Thank you.
discussants.
Thank you very much, Dr. And thank you, organizers, for having me. It's always great fun. I've been listening from beginning, learning a lot. Can I please invite my discussant, Dr. Amit Agarwal and Dr. Chirag Desai? Are they both there?
I'm there, Nitesh, I'm there.
Okay, excellent. So I think Monday morning, we'll start with this. We'll go through RX Ponder, PAM, and the neuroendocrine therapies and metformin. I am repeating some slides, but I want just a deeper discussion on these topics because I think they're very relevant. Amit, what's your current practice with regards to node positive, hormone receptor positive, and one disease?
It was till date giving chemotherapy to almost all node positive patients. We were hoping that the stroke data would get reciprocated, and it is getting reciprocated in a fair large chunk of population. So I have shifted to what our treatment RX ponder or responder, whichever way you might say. I've started practicing in the line of that.
And Chirag, were you considering some postmenopausal patient at least already for not giving chemo in node positive group?
Yeah, so that's correct. But I slightly differ in my practice. I don't have the luxury of offering oncotype to many of my patients. And in view of that, I am okay with using the Indian version of CanAssist in some of my patients looking at the retrospective study. Basically, we want to look at the biology of the disease that will drive whether patient requires chemotherapy in addition to hormone or not.
And Amit, you're comfortable with that?
No, I don't. I'm not comfortable with that. I think the question that is being asked is CanAssist versus Oncotype DX.
Yeah, correct.
Yeah.
And not comfortable with
Okay,
that.
they've
Would
recently had a
would the
very good publication come out too, actually, quite authentic.
I
Anyway,
agree, but would the biological behavior as decided by Oncotype DX would be equivalent to biological behavior as
Dr.
decided by
Nitish,
CanAssist?
can I just put one question in, just to hack minds
please,
of
please, please, Manish,
discussants?
please.
My question is one node versus three nodes. Any difference in perspective?
Amit, you
There is no
first,
difference.
Chirag, you second.
There is
And
no
I'll
difference
say,
between 1 and 2 node, 2 and 3 node, 1 and versus more than 1 node in the data set.
Chirag?
If there was a difference, it would not have been called N1 because N1 and N2 basically are different. So practically we can say that all N1 should be similar unless we
I'm
have the
referring to
evidence.
the SWOG 8814 trial, which was a smaller trial, which had that the benefit is very less in one node positive, but they can't really say about
Manish,
two
I
and
think I
three
hear
nodes.
what you're saying. Interest of time, I think I'll conclude by saying there's no difference. This was a huge study. It was prospective. And I think now that it's here in 2021, San Antonio, I think we are all obliged to follow this more than everything else that preceded it. What is being reported here is the IDFS and the DRFS, which is basically with this schema, recurrence score was segregated, menopausal status, and axillary lymph node also. What is your view on the attributes in the follow-up? What's your view that this study was well conducted, and is this long-term follow-up good enough in hormone receptor positive patients? Amit first, Chirag second.
So there is no major difference between last year's update,
Correct.
initial presentation and now. It just adds one more year of.
But do you feel 5 to 6 years is adequate follow-up for the ER positive luminal A kind of tumors,
So far
luminal A,
so good.
luminal B?
So
Okay.
far so good. I would need another 5 years, but I think Shalaka mentioned a point there that this was so far an updated planned analysis. Is 10-year analysis is a part of a plan? If it is a part of plan, then it will have power to say so. But yes, I would rather want a 10-year analysis, but so far so good.
Okay, Chirag.
I agree because the shorter versus longer follow-up will only tell you whether you should give hormone for a longer time or a shorter time. It doesn't convey that whether chemotherapy should be given or not. Chemotherapy benefit is for initial few years, and that is very well demonstrated in these curves that
That's a
it
great
doesn't work.
point. That's a great point, actually. Yeah, you make a great point that will be hormone therapy follow-up. So
Yeah,
so essentially,
so the article itself mentions this fact what Chirag is saying, that chemotherapy has never been shown to have survival benefit, extra benefit beyond 5 years. So
yeah,
whatever
yeah,
benefit you're supposed to see for the chemo as such, you have seen.
yeah, yeah. I think we'll buy that. On that note, at least if anybody else feels differently, everybody who's hearing, I think to my mind this was very clear that for postmenopausal women with a score less than 25, N1, more or less, it is now not an era of chemotherapy anymore. Chirag, Amit, any different views on that?
That's true.
Okay. So, okay. Now, this was the bit which really, I think, needs a lot of discussion, the premenopausal group, because of course and the ma'am rightly presented that some of this was subgroup, although this was a pre-planned analysis, premenopausal benefit. And clearly there was in the population at large, there was a benefit of giving chemotherapy. And on that note, I think it is safe to summarize that at a kind of intention to treat analysis, if you have a premenopausal patient with N1, would you say we should not do oncotype DX then? Chirag and Amit?
So yeah, I agree. Looking at these curves, we should not do oncotype in N1 patient, and we should straightway give chemotherapy followed by hormones. The very fact is that we want to define the disease biology and responsiveness to hormone therapy alone, and oncotype at least is failing to that extent in node positive premenopausal patients.
Amit?
So that's true. It may have a prognostic value. It does not have a predictive value. So if you want to
Yes.
find out, so if we have to answer the question whether the chemotherapy has to be given or not, then I think there is the answer. But if it values to give prognosis, then you might have to do it. But we never use oncotype DX for prognostication. We always use it for deciding chemo versus no chemo. So I think I second what Chirag said.
Okay, so one thing we've concluded is for Monday morning, post-menopausal, we are not giving chemotherapy, and for pre-menopausal, unless they want to understand their risk, for the sake of chemo or no chemo, we are actually not doing oncotype DX because at least in the intention to treat kind of analysis, it is clear.
Dr.
Now
Nilesh,
this
Dr. Advani made a very important point in his discussion that a patient who is very near to menopause and is not willing for chemotherapy, whether making them postmenopausal by oophorectomy or ovarian suppression in some form, and making them postmenopausal, would it amount to treating them as postmenopausal, or would it still amount them to treating as premenopausal and offering chemotherapy?
So I think your Manish answer will come in a minute when we look at the hormonal curves, and I want to deep dive into that. And so hold that thought, and I think we'll address this question separately in a minute. Post hoc, premenopausal, N1 MIC. Any thoughts on that, Amit and Chirag? Amit?
So it's a very small number. Exciting to see that. Does it represent just sheer play of the number games, or if the biology of the disease, whether it is microscopic 1, 2, or
So,
3?
so you know what the question here is now. The question is ERPR positive, HER2 negative, premenopausal women who are MMIC. Will you
Yeah,
send Oncotype DX? Because we've just said for N1 we will not. N1 MIC, would you send Oncotype DX?
I will send it.
Okay, Chirag?
So N1 MIC is 0.2 to 2 millimeter of the tumor. It is more than the isolated tumor cells, and I will call it N1, and I will not send. I will give chemotherapy.
Okay, yeah, true. So let me say the other way around.
Yeah.
Chirag is right. My thought was that would we treat it as a positive node or not? So if we would
Okay.
take it as a positive node, then you would not send it. That way Chirag is correct. Correct.
Would you consider it a positive node? Manish, you're very excited about this issue. Would you consider this as a positive node?
I think the trial did not recruit any further NMIX later on in the second half of the trial. Wasn't that like that?
So the point is,
Doctor,
Nitesh, is would we ever get an answer to this question? This
I don't
trial
think
was
so.
not.
No,
So
I don't think
if
so.
we are
I
not
don't
going
think
to
so.
get this question answered, then this is
I,
the only data which is going to stay with us.
and to be fair, this is younger population, and I think we have erred on the side of caution given chemo for last 40 years. So I don't know. Dr.
As a
Ramesh
matter of
Sarin,
fact,
your
the
final.
advantage was higher. It was 7.8%
It
as
was.
compared to lesser advantage in N1.
It was. And I think it was defining a biological group, in fact, where NMIC was more towards N1. Dr. Ramesh Sarin, your final word on this. NMIC, would you consider them as node positive and not send, or would you send them for Oncotype DX?
I would go in favor of sending the Oncotype DX, and if the results are low scores, 0 to 13, there is a point, there would be a point in doing their ovarian function suppression and putting them on endocrine therapy rather than subjecting them to chemotherapy. But if the scores are higher and the woman is young, less than 35, I would err on the side of chemotherapy.
I think ma'am makes a great point, but I will leave that argument for later.
Can I take a
Otherwise, we
point
will.
there?
Please,
Ideally,
Amit.
you would give chemotherapy in all these patients because there was increased benefit even in low risk.
Correct. So this
So
trial is an outlier.
why send Oncotype DX?
Yeah, so this trial is an outlier. It says that whether you are 0 to 13 or 13 to 26.
7.3% versus lesser benefit in N1.
Yeah.
Maybe a function of
That is
numbers,
what I was
but
trying to
then
show.
maybe a
That is,
function of numbers, but
yeah, I think we will continue to debate on this. Personally, I would give chemotherapy to this group because until more data maybe matures in other kind of equivalent studies, I would want to give chemotherapy. This number, although small, was quite large. Having said that, this was actually a subgroup analysis, so we'll have to take a case-to-case basis on this. Very important. This can I start, Amit, with you first? Do you feel this was
Sir, I would request now, so since the time is
okay?
more,
I'll
so
I'll
we
I'll
need to
I'll
conclude. Yes,
I'll
there are
conclude
2
very
minutes left.
rapidly. Okay,
2
give me
minutes
2
left.
minutes. Amit,
Thank you. Thank you.
I think the most important point is what Manish was trying to say. Would you believe that the hormonal suppression or OFS impacted or not? Because at least this study said that OFS or no OFS, you should give chemotherapy to these patients.
So
Amit and then Chirag.
it's very confusing. So it seems that in a small number of subgroup analysis, there was no difference in an ET group who received OFS or who did not receive OFS. They were more or less doing the same. I mean, it's very confusing. I would have expected OFS to make a dent. I could not see the dent, whether it was because only 16% of patients received OFS. On the other hand, achieving an amenorrhea was so great. So that was either an amenorrhea achieved with OFS or that was an amenorrhea achieved automatically because of chemotherapy.
We don't know
So
that.
is the biological amenorrhea of chemotherapy and the amenorrhea of OFS different from each other? We just don't know. But this is don't know, difficult to swallow and digest. But anyway,
Chirag.
that's what the data is.
Chirag.
So I will not try to dissect what Dr. Amit was trying to do, whether amenorrhea is because of natural amenorrhea or because of chemotherapy. But if I decided to give chemotherapy, the patient was sufficiently high risk to qualify for adding ovarian function suppression, not other way around.
Okay, so I'll move forward. My take is that there was a benefit of chemotherapy despite of hormonal, but Amit and us, we can discuss at length later. Very quickly, this was PAN 50. My only question to you, and we can go into details. It was very interesting, in fact, to read how the group was divided, but I am short of time. So my question is, does this change practice? And very quickly, without PAM 50, looking at this data, would you consider some patients for neuroendocrine therapy and others not? Chirag first, Amit second.
So if PAM 50 is the luminal A as well as the low risk, I might give the patient only hormone, either as neoadjuvant or adjuvant.
And would you do KI67 like they did at week 4 and week 12?
So that was the part of original trial. So yeah, we may, but we could see that PAM 50 was giving that answer ahead of doing KI67 at week 4 and
Okay,
week
and
12.
and without PAM, would you consider somebody for neoadjuvant therapy? Any soft
Not really.
indicators?
Not really.
Not really.
Not
Okay,
really.
Amit, your final conclusion, and
So
then I'll do a last
never
slide.
used PAM 50, will not be comfortable. I use neoadjuvant therapy with hormone only in those patients who are absolutely not willing to take chemotherapy and clearly not eligible for chemotherapy, and the surgeon says they cannot operate. That's the only patient, and I take the consent from them that they will not be going for chemotherapy later on because of them. That's the only patient I gave neoadjuvant hormone therapy.
Okay, I will very quickly conclude this also. This was a, I think, very good study because we know obese patients do badly. Metformin has benefit and clearly showed there was no benefit in either group A or group B, and the HER2 was fantastic. Any take on this? This I think was a very brilliant a small group who have any ATM mutation of whatever sort in the SNP who benefited. Chirag first, Amit second, and then we conclude.
So it is interesting, and it awakes my curiosity. Nothing more than that on this trial.
You think in 5 years in San Antonio, we'll be having a much bigger prospective study on this?
I don't think so. I mean,
Okay,
let's
Amit.
hope that there comes something.
Amit?
Metformin is an excellent drug for type 2 diabetes mellitus.
Thank you. I think I'll conclude on that, but I'm very excited by this, but maybe I get overexcited by molecular. I'm very excited by this. I think this is a new biomarker, and I'm waiting for more study on this. Thank you very much. Dr. Arun, back to you, sir.
I think that's the end of this session, and I would hand over back to the organizers to continue with the proceedings. Thank you.
Sure, sir. So thank you, Dr. Nitesh, Dr. Mamit, and Dr. Chirag for the excellent discussion. Next, I would like to invite our next chairperson of the evening, Dr. Bhavna Awasthi, who is Senior Consultant Medical Oncology at Fortis, Vasant Kunj. Over to you, ma'am.
Thank you. Thank you, everyone, and good evening. I know we are running late, and I would like to start off by thanking the organizers for giving me this opportunity to introduce. And we are all aware of the ABC trials, the large meta-analysis which talked about the role of anthracyclines. And here I would like to invite Dr. Ghanshyam Biswas, Consultant Medical Oncology, Executive Director, Holler, about the anthracycline versus taxicaltetracycline. This is of 16,500 women with early stage breast in 13 randomized trials.
Yeah, thank you, Bhavna ma'am, and thank you, organizers. A very good evening and Happy New Year. So another update. So a few years from now, we'll have only COVID update. So we're talking about taxanes with anthracyclines and taxanes without anthracyclines, a patient level meta-analysis from the EBCTCG group. So the background that anthracyclines and taxane-based chemotherapies for early breast cancers reduces the risk of breast cancer mortality by about 1/3 as compared to no chemotherapy. So definitely we have concerns in anthracyclines, cardiovascular, and at times secondary malignancies like leukemia. In taxanes, so definitely neuropathy, and that too for paclitaxel. So for some reasons, increasing use of non-anthracycline based chemotherapy has been there. So methods, the aims was to better characterize the benefits and risk of anthracyclines and taxanes chemotherapy for early stage breast cancer. So all eligible randomized trials that started before 2012 were included, and it also took at least those patients, those trials where at least 6 cycles of chemotherapy in each arm were received. So primary outcomes were recurrence and a breast cancer mortality were analyzed according to the ABCDC methods. So these were the 4 groups. which included in total of over 18,000 patients, and this included only almost 16 trials. So let us look at the group A, which is a concurrent, like 6 cycles of concurrent PAC versus TC. And the second was a sequential anthra followed by taxanes versus, you can see a higher dose of docetaxel plus cyclophosphamide. So probably this is the new generation regimen. So that's why probably we have more patients in this group. Third is a taxane plus anthracycline versus higher cumulative dose of taxanes with or without capecitabine. And the fourth group was taxanes plus anthracyclines again versus higher cumulative dose of taxanes plus carboplatin. So only in the A where we can see a docetaxel of same doses was used. So coming to combined analysis of all these 16 trials from A to D, if you look at the recurrence, so the 10-year gain was 2.5%. So that was if we have added anthracycline to taxanes versus only taxanes. If you come to a specific mortality, breast cancer mortality, so 10-year gain was 1.6% in favor of the combination taxanes and anthracyclines. If you compare these, the trial comparisons from A to D, so you can see so concurrent versus sequence versus group C and D. So in every group, you can see, so and the taxanes and anthracyclines has favored, but probably in the sequential arm, so probably it was just touching the unity line. So taxanes with anthracyclines versus docetaxel plus cyclophosphamide. So we are talking about the concurrent versus sequential, that is A and B. So around 14,000 patients, median follow-up of 5.3 years. So if you see, look at the group A, so 2/3 of the patients were hormone positive, ER positive. Group B, around 3/4 of them were positive. Node positive, again 2/3 in the group A, again almost 1 out of 2, that is 50% in group B were hormone positive. So less number of HER2 positives were there. So taxanes with anthracyclines versus docetaxel plus cyclophosphamide we can say a same doses. So you can look at the dose here. In the group A, you can see, so doxorubicin was given as a cumulative dose of 300 milligram per meter square, but docetaxel in both these had a 450 milligram per meter square. In the sequential group, you can see the epinephrine was 300 milligram per meter square, but look at the docetaxel component here. So 300 versus 450. So higher dose of taxanes was used. So comparison of A versus B in regards to recurrence, you can see the concurrent. So in the concurrent, that is TAG versus TC, you can say. So the 10-year gain was significant, 8.7%. And in the sequential, so the 10-year gain was hardly 0.6% as compared to the combination of anthracycline versus taxanes alone. Coming to cancer-specific mortality, breast cancer, in the concurrent arm, the 10-year gain was 4.2% in the taxanes plus anthracycline as compared to taxane alone, whereas in the sequential, the 10-year gain was not significant, that is 0.3%. So if you take about ER negative and ER positive, we have seen that ER positive were almost 2/3 of these patients. So the 10-year gain was 6.3. So 1/3 of the patients who were ER negative, the gain 10-year gain was substantial to 13.2. And we know that so hormone negative patients benefits more with chemotherapy. So comparing A in the nodal status, so be it
Apologies,
N0,
sir. You are just left with 1 minute to conclude your
So
presentation. Thank you.
N0, N1, 2, N3, N4. So everybody has benefited. Maybe the quantum of benefit was more in the N0 group. So the toxicity and quality of life combined analysis, no statistically significant difference in death without recurrence, no difference in deaths from a cardiovascular disease or a secondary malignancies like leukemia, but maybe longer time follow-up will help us. Individual patient level data on quality of life and toxicity not available. So to conclude, if you put together all these trials, the 4 groups, over 18,000 patients in the 16 trials, 15% proportional reduction and 2.5% absolute reduction at 10 years in the risk of invasive recurrence for anthracyclines plus taxanes versus taxanes alone. 42% proportional reduction seen with concurrent schedules, taxane dose remaining same in both arms. The only difference probably was added by anthracycline. So little, if any, benefit in the trials of sequential anthracycline taxanes versus was a higher dose of taxanes. So proportional reduction in recurrence did not differ by the ER status or the nodal status. So acknowledgement to the EBCTC group. And so we are already into the third phase. So restoring the balance for cancer care in the COVID-19 area. Thank you, ladies and gentlemen, for the patient hearing. Stay safe. Take care.
Thank you, Dr. Ghanshyam. That was a in the interest of next presenter, the head of department and senior oncology at Bangalore. He's going to talk about the quality of life results here, which is the center randomized placebo-adjuvant olaparib after neoadjuvant.
Dr. Rahul Sood, please start your presentation.
So you can start.
Late, so let me start. I hope I'm audible. So I'll be talking about the quality of life results from the Olympia A trial. We all know about the Olympia A trial. So this is the quality of life results from the trial. So we know that the Olympia A trial was the randomized double-blind placebo-controlled trial, which tried to give olaparib was vis-a-vis placebo for a period of 1 year after the patient had received neoadjuvant treatment. There was an invasive disease-free survival benefit, which, however, did not translate into an overall survival benefit. This was published in the NEJM 2021. So the rationale of presenting this paper was to see the patient-reported outcomes, especially the acute toxicities in early-stage breast cancer, especially when people have already got the chemotherapy upfront. There was a problem of fatigue, which used to happen to these individuals, especially when they used to have adjuvant hormonal therapy. So the question was whether a continuation with a PARP inhibitor like olaparib did exacerbate the toxicity and also the disease-free survival, which was better. So vis-a-vis, how did the two go together? So this was the study population, the neoadjuvant and the adjuvant, the comparison between olaparib and placebo. This was the study, and ultimately the patients were continued on olaparib for 6 months, 12 months, and then extended up till 18 and then 24 months. So the primary objective of this study was, like I said, to find out the fatigue at 6 and 12 months, and this was done by the FACIT fatigue analysis score. The secondary endpoint was stretching the same thing beyond 12 months, that is 12 to 24 months, and also to look for not only the fatigue, but the GI symptoms which is associated with olaparib, and the functional quality of life, and most importantly, the global health status. Very, very difficult study, and how did they analyze it is another story altogether. In the next 7 minutes, which I have, out of which I've already taken 2.5 minutes, this was the analysis plan which was done, and the sample size was done, and these are the various parameters under which the analysis took place. The cutoff was in March 2020, and this was then presented. So this is how the population went, started with about 2,000 patients, cut down to 1,700, and then equally divided into neoadjuvant and adjuvant, and further into the olaparib with placebo arm. If you see the comparison between the two groups, very well matched with age, race, and geographical region. Also matched for prior chemotherapy, neoadjuvant and adjuvant surgeries, and the various chemotherapy regimes received. So now this is where I really stop and start again. So if we see the pro scores of the fatigue, we see that there is nothing much to choose between the two. That is 39.4 versus 39.7 in the neoadjuvant group, and 40.9 versus 40.7 in the adjuvant group. Even if we see the various other side effects, that is the nausea, diarrhea, global health status, physical subscales, and emotional, there was nothing much to choose between the placebo and olaparib. So if you can say that olaparib was probably non-inferior to placebo when it came to these side effects. Going forward, this is important. 6 to 12 months, that is the primary endpoint. And when we say the negative in front of the hazard ratio, the negative number indicates an increase in the fatigue in the olaparib arm. This was higher in the olaparib arm vis-a-vis the placebo arm. And this was statistically significant. So the initial fatigue was more with the olaparib, and this is something to worry about. But what about the secondary objectives? And when I mention the secondary objectives, the scores beyond 12 months up to 24 months. And the difference starts now to become together. That is, the negative starts becoming positive or becoming next negative. So therefore, over a time period, the fatigue severity decreases in the olaparib arm. And if we see the nausea and vomiting, that is what also happens. And the nausea and the vomiting also decreases as we go forward. If we see diarrhea, another similar kind of thing, as we go forward beyond 12 months, the diarrhea also reduces. That is, the patient becomes accustomed to the PARP inhibitor as it goes forward. What about the physical functioning? No difference was seen. What about the emotional functioning? No difference was seen. And most importantly, the global status of the quality of life, there was no difference between the two arms. So what are our conclusions? Like I mentioned, the fatigue severity was more initially till the 12 months, but over this period of 18 to 24 months, the fatigue was similar in both the arms. The nausea and vomiting, yes, again was higher initially, but over a period of time, the nausea and vomiting decreased. No meaningful difference in the other parameters like I showed. The study had limitations. Yes, it was more of an objective study. The quality of life is usually an objective finding. Direct comparison between two groups, it was another point that was there. So what is the summary? This is what they summarize, but I would like to add to what I think about the study is, yes, the drug works. It provides a progression-free survival benefit, but would we use it? Only time will tell. The quality of life and nausea and vomiting is important. Could you please mute the background, please? But the 1 year of olaparib did not meaningfully affect the recovery of a standard neoadjuvant therapy. Would I use it? As of now, no. Apart from all the other toxicity, the financial toxicity is the biggest toxicity, which is not talked in the paper. If the cost of the medicine comes down, something to look forward to. These are my acknowledgements. Thank you very much.
Thank you, Rahul, sir. Thank you for the excellent presentation. And we would like to move further. And next session is sponsored by our academic partner, Novartis. And for this, I would like to invite Dr. Manish Singhal, who is Senior Consultant, Department of Medical Oncology, Indraprasth Apollo Hospital, New Delhi. He's going to talk on consistently superior OS with Crixania in HR positive, HER2 negative ABC. Over to you, Manish, sir.
Yeah, thank you. Can I request the slides to be shared?
Sir, Karima.
Yeah, thank you. So I'll be speaking on the consistently superior overall survival with Crixana. And the next slide, please. Next slide. This is the disclaimer from the company. So we have seen that Crixana is indicated for the treatment of not only premenopausal but also postmenopausal women. And this can be combined with aromatase inhibitor with LHRH agonist or with fulvestrant as a treatment, as an initial treatment and also second line treatment. Next slide. So the objective is to review the evidence supporting the superior efficacy of Crixana and the evidence of improved or maintained quality of life, as also to discuss what makes Crixana different from the other CDK4/6 inhibitors. Next slide, please. It is about living longer, living well, and living longer without chemotherapy. So these are very important endpoints as far as the efficacy of an additional drug to hormone therapy is concerned, which is well achieved by this particular drug, Trixana. So the overall survival is well cited as a treatment goal, and performing daily activities is also important with good quality of life, and so is delaying the fear of starting chemotherapy. Next slide. So superior overall survival data I'll be discussing. So is the improved quality of life, and delaying chemotherapy for over 4 years if you start these patients on a CDK4/6 inhibitor Trixana and their hormone partner. Next slide. So this has been studied. The drug has been studied in diverse patient population, including premenopausal and postmenopausal women, both in first line and second line. Next slide. So this is putting all this evidence together. Mona Lisa 2 was a trial which was done in first line. All patients were first line, and they were randomized in postmenopausal women to AI alone versus AI plus Trixana. Mona Lisa 3 was in first line and second line. There was a 50-50 divide between first line and second line, and it was postmenopausal women, and it was combined. The combination partner was fulvestrant, whereas Mona Lisa 7 was in premenopausal first line patients and perimenopausal women, and it was combined with LHRH agonist and aromatase inhibitors, although a small population also received tamoxifen. Next slide. So it is one of the only CDK4/6 inhibitor which has shown to have longest reported overall survival across 3 phase 3 trials. Next slide. Next slide, please. So discussing Mona Lisa 2 further. So this is the overall survival. So we have crossed the 60 months, 5 years mark, with median overall survival reaching 63.9%, 9 months versus 51.4 months with placebo plus letrozole, with a delta of around 12.5 months. That is more than a year increase in median overall survival. And there was almost about 25% or 24% decrease in the risk of death or death as an event with the use of Trixana with letrozole in first line. Next slide. Overall survival benefit also increased over time. So at 6 years, the delta was about 12.2% as compared to 5.7% at 4 years. Next slide. The patients also, the subsequent treatments was quite similar between the two arms. As a matter of fact, more patients in the control arm received CDK4/6 inhibitor as compared to Trixana, patients on Trixana. Also, otherwise, the number of therapies received in both arms were quite similar. Next slide. So the next endpoint is time to or delay in the time to start chemotherapy with preserved quality of life. Next slide. So again, as you can see that the delta is about 12 months. So there was significant delay in the time to start chemotherapy over 4 years, and that was increased from 38.9 months to 50.6 months. Next slide. Progression-free survival was improved from 16 months to 25.3 months with a delta of around almost about 10 months, and that was the Trixana and plus letrozole delivered 43.2% reduction in the risk of progression. Next slide. There was definitely rapid responses which were seen, and the separation of the curves was seen at the first assessment, that is at 2 months, that is 8 weeks, and one can see that there was increased response rates with the addition of Trixana. Next slide. Almost 3 out of 4 patients could see some reduction in their tumor size at 8 weeks. So the responses are quick to start, although the depth of responses can take time, but they are quick to start. Next slide. So if you divide these patients into 4 groups, that is a decrease of more than 60% or around 60%, at least 60% is group 1, 35 to 60% decrease in the volume of the disease as group 2, and 14 to 35% as group 3, and stable disease as group 4, that is smallest decrease in the tumor size. Next slide. So almost doubling of patients who had around 60% decrease, at least 60% decrease in the tumor size. So there is definite increase in the percentage of patients who could get a better decrease in the disease process or overall disease volume. It was also improved for group 2, but of course group 3 and group 4, where there was lesser decrease, that was more common with letrozole alone. So more patients with addition of Krixana could get higher tumor shrinkage. Next slide. So consistent superior overall survival was achieved, and this was also true with Krixana plus fulvestrant and Krixana plus AI and LHRH agonist in premenopausal women. Next slide. So if you look at the ISMO median clinical benefit score, which is considered 4 and 5 is considered the best, with Monalisa 7 and 3, the score, the ISMO MCBS score, that is the median clinical benefit score, was 5 and 4 with in Monalisa 7 and 3. That is, the therapy achieves a good grade of improvement, not only as median overall survival gain, overall efficacy score, and also maintaining good quality of life. Next slide. So why is Krixana unique? So the majority of oncologists believe that median overall survival should be reached, which is achieved with this particular drug. CDK4/6 inhibitors should change the treatment paradigm, which it does. And this is not achieved by all other CDK4/6 inhibitors. And definitely it makes a difference in survival of our patients. Next slide. Next slide. Yeah. So the CDK4 seems to be the critical driver between CDK4 and 6. So CDK4 perhaps is a more important driver, and the available drug that penetrates the tumor cells should also be on the higher side when it binds to and inhibits the CDK4. Next slide. So breast cancer patients have more CDK4 dependent cells as compared to CDK6, and Krixana results into more CDK4 inhibition as compared to the CDK6 inhibition. Next slide. So there's a unique CDK4/6 inhibitor which has it inhibits CDK4 8 times more than CDK6, which is higher than both palbociclib and abemaciclib. Also, the drug available to bind is 22 times more as compared to palbociclib and abemaciclib. This is a putative reason of why Krixana is achieving more overall survival benefit as compared to other agents. But this is just a hypothetical information. But this is the preclinical data which shows that the Krixana is definitely a different CDK4/6 inhibitor. Next slide. So number of off-target kinases is much lesser with ribociclib as compared to palbo and abemaciclib. So it inhibits only 4 off-target kinases, which is much more with palbociclib and abemaciclib, which perhaps redoubles the endpoints which are achieved by Krixana. Next slide. So the preclinical data highlights that the power of Krixana is higher, and the steady state RB inhibition is achieved in 90 to 94% with Krixana as compared to 55 to 60% with Abema and palbociclib. So Krixana delivers powerful and precise inhibition of CDK4/6 pathway and causes arrest in the cell cycle and slows the cancer cell proliferation. Next slide. So another subgroup analysis from the complement-1 study, which looked at patients who had CNS metastasis and spinal cord metastasis. And next slide. So it did show that those patients who had CNS metastasis perhaps fared almost as good as in terms of time to tumor progression as compared to those who were all comers. So if you look at those patients who had the median overall survival in patients on ribociclib and letrozole in the total population was 27.1 months in this particular study, and was not reached with brain and spinal cord metastasis. Well, whether this means that ribociclib achieves therapeutic concentration in the CNS, that's not sure, but it does control the systemic disease well enough so that there's no new CNS metastasis, is what I would conclude. Next slide. So it offers a convenient dosing and administration. There is 3 tablets of 200 milligram with or without food. There's no adjustment with food, and one can easily go down on the doses. So there's no waste of drug. Next slide.
Sorry to interrupt, sir. You are just left
Last
with 2
slide. This
minutes
is
to
last
conclude.
slides. This is the summary.
Thank you.
So only Crixana has the longest median overall survival reported for CDK4/6 inhibitor in pre and postmenopausal patients. So living longer, superior overall survival is achieved. Nearly 4.5 years median overall survival in first line and second line postmenopausal women. At 5 years, more than half of the first line postmenopausal women are alive, and nearly 5 years is the median overall survival in first line premenopausal patients with Crixana and AI. So living longer without chemotherapy is achieved, living well is achieved, and living longer is achieved. With that, I thank you for your kind attention, and back to the organizers.
Thank you so much. Last but not the least, we move to today's last session of the evening, panel discussion on the topic Changing Paradigm in the Management of HR Positive, HER2 Negative ABC. And for this, I would like to invite our moderator, Dr. Devrath Arya, Director, Medical Oncology, Max Hospital, Saket. Over to you, sir.
Yep. So thank you very much for the introduction, and let me very quickly, invite my panelists. So let me invite Dr. Nagendra Sharma, Dr. Pankaj Goel, Dr. Preeti Agrawal, and Dr. Vineet Govind Gupta. Can I have a hello from all of you?
Hello, sir. I'm there.
Hi, Nagendra. Yeah, I'd request you to switch on your screens so that you are visible to me as well. Dr. Preeti, are you there?
Yeah. Hello.
Hi. Dr. Pankaj.
Hi, sir.
And Dr. Vineet. Vineet, are you there?
Yeah, I'm here. Hello.
Yep. Hi, Vineet. Hi. So this is a Novartis sponsored session. We've quite obviously, we are going to focus on ribociclib. We've heard a very lucid talk from Manish. He talked about the long-term results from the Mona Lisa 2 study. I think astounding results, very impressive 5-year survival, in fact, median OS as well. I think in the interest of time, and we are the last session here, so we are kind of the sloggers here. So very quickly to the questions here. Right. So, when you have all the treatment options available to you, Dr. Nagendra, so, what is your endpoint? Would you choose therapy based on the quality of life, efficacy in terms of PFS, OS? How do you decide your treatment?
So the question is already answered by Dr. Manish, sir. So the primary endpoints we will be focusing on whether patients are living longer, whether patients are living well, and whether the patients are living longer without chemotherapy. So obviously, as a medical oncologist, we always chase for median overall survival. But yes, if we are in advanced stages, we know that we have to keep this patient as good as possible for as long as possible. We will be happy if the patients are having median overall survival benefit, median PFS, and they are having good safety or quality of life, and adverse events are well tolerated. So all these are equivalent, but priority top of the list is median overall survival.
So you want all of it. So let me change the question slightly. We have so many CDK4/6 inhibitors. Some of them have actually come up with a statistically significant OS advantage. Some we haven't got that data. So would you base your treatment choice of CDK4/6 on the OS data that's available, or you think that's just a class effect?
Right. Not only overall survival which drives the decision, it's the median PFS also, and the quality of life also will focus upon. So we have to see whether it's a primary endocrine resistance, secondary endocrine resistance, or a de novo metastatic disease. What is the organ reserve, safety profile? Is there any contraindications? So all this factored into the decision. But on the top of the list, obviously, median overall survival I will be focusing on.
Fair enough. So Dr. Vineet, we have all the choices available. So we presume you have a lady with a de novo metastatic breast cancer, does not have a visceral crisis. I think that kind of rules out chemotherapy. So when it comes to the treatment options, what is your choice? Would you offer CDK4/6 to all your patients? I think there's a select subgroup of patients where a CDK4/6 not necessary.
No, sir. In the absence of contraindication, all my patients will get CDK4/6 inhibitor upfront. And at present, I will go for option B. So
you
aromatase inhibitor and CDK4/6 inhibitor.
You would opt for CDK4/6 and aromatase inhibitor. Dr. Preeti, we've had the Mona Lisa study in the postmenopausal women, but actually fulvestrant could have been used in the first line setting. So do you use that option, a CDK4/6 fulvestrant in a purely first line setting, or you reserve fulvestrant for a second line setting?
I usually reserve fulvestrant for second line setting. I usually use AI as a first line.
So you would use AI in a first line. I think I have not involved Pankaj so far. Pankaj, your thoughts on this?
Sir, I think it's better to reserve that for second line, because if you want to use PIK3 inhibitor later on, then I think the partner preferred agent is fulvestrant. So better use fulvestrant in second line and let the AI plus CDK inhibitor be the first agent.
So beyond choices, Dr. Nagendra, do you think, I mean, they did use fulvestrant in the first line setting. So, do you think in your interpretation of data, do you think ribociclib fulvestrant is actually sitting better compared to ribociclib AI, or both are equally good?
Right. So this is always a question which always will be on the back of our mind, whether to use CDK4/6 inhibitor with the aromatase inhibitor or fulvestrant. So there are two things which we have to think of whenever we are taking a decision. First thing is, in the primary endocrine resistance, I'll be using CDK4/6 inhibitor with fulvestrant. But in a secondary endocrine resistance, I will be more inclined towards AI as a partner of CDK4/6 inhibitor. We know that 3/4 of the patients will be having secondary endocrine resistance. Only 1/4 of the patients will be having primary endocrine resistance. And as a CDK4/6 inhibitor also, I will be more inclined toward abemaciclib in a primary endocrine resistance. But if it is secondary endocrine resistance, the data is more mature enough for the palbociclib or ribociclib, because the hazard ratios are favoring slightly better for abemaciclib as far as primary endocrine resistance as a partner. But these are the factors. But recently, third wave of COVID is knocking the door. I'll be happy to use CDK4/6 inhibitor AI because it's more compliant. Patient can take it at home. But fulvestrant with CDK4/6 inhibitor, patient have to come to hospital. So I'd want to minimize the risk of COVID infection. So these are the factors which decides what is my treatment of choice. CDK4/6 inhibitor with AI.
Can I make a comment? Can I make a comment?
Yes.
So there is no head-to-head trial of aromatase inhibitors with fulvestrant other than Perceval.
Yeah, there's a phase 2 study. Yeah, you're right.
Where
So,
fulvestrant actually failed as a first-line therapy with palbociclib, though not with ribociclib. But at least one head-to-head trial of aromatase inhibitors in the background of a CDK4/6 inhibitor.
Yeah, so I think that's that was a fairly big study. I don't think it was a negative study, but it
was
did
a phase 2
fail
study.
Yeah, it
the
was a
hypothesis
phase
was
2.
that fulvestrant would be better off. Actually, the fulvestrant was worse off.
In fact, the median PFS was a little inferior with the CDK4/6 with fulvestrant compared to CDK4/6 with AI. I think the whole idea came probably to some extent from the Falcon study in the first line setting, where fulvestrant actually did appear to be a little superior to AI. But I guess I would agree with the opinion from the panelists that even I, in my practice, would reserve fulvestrant to a second setting, mostly if a patient would take a CDK4/6 with AI. But Dr. Nagendra did raise the point of primary endocrine resistance. Dr. Pankaj Goyal, your thoughts on it? He feels that primary endocrine resistance abemaciclib data is better than the others. You agree? Do you think that was just an exploratory subgroup analysis or post hoc analysis? What are your thoughts on that?
I think it will be it was just a subgroup analysis, so too premature to rely on that and have it tilt towards abemaciclib. Though abemaciclib also happens to be a good drug with good data, but the problem is the tolerability is not very good. Maybe in the patient with brain mets, I'll have a preference to abemaciclib. Otherwise, we are comfortable using the other cyclin inhibitors as far as the tolerance is concerned.
Yeah, so I think you've raised a very good point. I also went through that data of brain metastasis. Now, I do believe that in all our practices, having a de novo metastatic hormone receptor positive patient presenting with brain mets is slightly unusual. Most of these would not have a brain metastasis. It did appear that abemaciclib achieved a fairly good intracranial concentration, but when you look at the small subset of patients who did have a response, I think 5% have had a response. Probably clinical benefit rate ranging 20-25%. So is not lighting the stage on fire, right? It does appear that there's some benefit, but it's not very exciting. Dr. Preeti,
Yeah,
Coming
it's less
to
than 10%, less than 10% chance of a response with abemaciclib. It's not that,
5%, I think
yeah, less than
5% or
10%. Yeah.
thereabouts. So it's not very exciting, and I think clinical benefit also into the tune of 20 to 25%. So not very exciting. I think you, Manish, you shared some data with ribociclib. I
That
guess.
was a complement one. It had a
Yeah.
few patients with brain and spinal cord metastasis, and they looked at the PFS, and the PFS was as good or as bad as general population or the intention to treat population. So I think
Right.
we don't know much about their CNS penetration still.
Or probably what we know is that the CNS penetration isn't very good, and especially when it comes to a real world practice translating into clinical benefit or responses. I guess most of us would still rely on radiation wherever possible in a setting like this. So we have this data. I think we've discussed this data in detail, and I'll actually very quickly skip through these slides because Dr. Manish has already done a very good job at sharing these. But coming to this menopausal status, and I think we do understand, most of us, that menopause, premenopausal women probably have more aggressive disease. There may be some reason to believe that these are less endocrine sensitive, although people may differ in their opinion. Dr. Vineet, a premenopausal woman with de novo metastatic hormone receptor positive breast cancer, do you choose based on literature? You're happy choosing any CDK4/6 inhibitor as long as you're using ovarian function suppression? Dr. Vineet, are you here?
Yeah, sorry, it's a bit open. So yeah, I am actually happy. So definitely, Crixana has the better data for premenopausal patients, but I'm actually fine with either of the drugs. It's not a big issue, but definitely data is better with Crixana. So that is the consideration.
So you're happy using either, because I think we, although Crixana did have an entire clinical trial designed for the premenopausal women, we did have a small subset of patients, all other drugs where premenopausal women were enrolled, but I think more so in the second line setting. Dr. Nagendra, your thoughts?
Yeah, I do agree, sir. Monalisa 7 trial for ribociclib, in which the data is very much amazing, and we are inclined toward using ribociclib with AI for premenopausal women with the ovarian function suppression. And no doubt about that, the overall survival benefit is the key highlight feature of the trial. And that's why I'll be more inclined towards ribociclib and AI for premenopausal women with OFS.
Dr. Preeti, in that study, you had the option of actually combining the drug with tamoxifen as well. Do you ever do that? Do you have any reservations regarding tamoxifen in combination with ribociclib?
Yeah, I usually don't do it with ovarian suppression. Usually start with AI and then ribociclib. Yeah.
Okay. So, well, I think most of us don't use tamoxifen. I am aware of some reports to say that the incidence of QTC prolongation seen with ribociclib, while very small, with AI is slightly higher with tamoxifen. I think that could be one factor where while tamoxifen was used, it was used in a very small subset of patients and may add to the burden of follow-up when tamoxifen is being used as a partner for ribociclib in this setting. So again, we have a lot of data for premenopausal women, but I think we have a subset of patients who did receive CDK4/6 along with the partner ET, even when they were premenopausal. We have the updated analysis from all these studies. So very quickly, coming to the one question that we keep on harping upon, keep on coming back to, I think increasingly we have all these subset analysis, primary endocrine resistance, CNS metastasis. I think we've looked at data in the adjuvant setting as well. And I think to some extent that also influences how we look at these drugs. But I'll start with Dr. Pankaj. In your thoughts, are all these drugs beyond cost, beyond side effect profile, are they same? I think what we are looking at in terms of benefit is a class effect, or you think there's much more to that? Dr. Manish talked about the CDK4 inhibition as well and the differential rates of that.
I think that's what I was saying. You cannot put all the drugs in the same basket because all of them have different side effect profile and also the efficacy as well. So it's not just like even in PDL1 inhibitors, we have seen that all of them do not behave the same. The way used to analyze in the beginning. So these have different selectivity towards CDK4 or CDK6, different intracranial concentration, and top of that, the side effect profile. So I think they have to be treated in a different manner.
So what would you use? We do have a network, so there's no head-to-head comparison. We do have a network meta-analysis suggesting that all the same in terms of efficacy. So what do you use? What is your go-to partner?
If patient is premenopausal, then I preferably, when we have overall survival data, then of course, so there's no reason why I should not use your ribociclib. Once we have the OS data, mature OS data. In postmenopausal, there is no particular preference, but depending upon the side effect profile, we might choose if the patient suppose is having already some liver dysfunction or something, we may not use ribociclib. Or if the patient has a history of taking some immunosuppressant, like drugs like methotrexate, when we know that the neutropenia will be higher, then probably we'll have the switch tilt towards the ribociclib. So it's a side effect profile and the menopausal status, which basically decides what the treatment should be.
So you're not impressed with the Mona Lisa 2 study, that the data that
you can use anything, but grossly these are the issues.
Fair enough. Fair enough. Dr. Nagendra, what are your thoughts? Your go-to CDK4/6 inhibitor?
So I'll put it, I will agree to Dr. Pankaj what you have told just now, but I will put it that they are all equivalent. They're not equal. If you cannot put that they are all equal in all the senses, obviously side effect profiles are different. Efficacies to this extent they are different. The monotherapy, like abemaciclib is available in monotherapy also. They are leverages. They are CNS mets. You know that the abemaciclib is a leverage for that. So all these points have to be taken into consideration. And what ultimately we want to achieve, I already told that we have to keep this patient as good as possible for as long as possible. So as far as now is concerned, premenopausal and postmenopausal, ribociclib will be my drug of choice, barring few exceptions, as everyone told that for CNS patients there is a leverage for abemaciclib. Otherwise, I'll be happy to use ribociclib plus AI or fulvestrant for majority patients.
Okay, so in the interest of time, I'll very quickly jump to the next set of questions. I think the key question that we ask ourselves is, what after CDK4/6 inhibitor? I think we are going to talk about the very interesting PADA study. I think I'm not going to steal the thunder of the speaker tomorrow, but it did appear that those patients who did have an ESR1 mutation could actually switch to fulvestrant from an AI and continue PAL-based with some benefit. And I think it can be discussed in greater detail in subsequent talks. But there really is no standard of care post a CDK4/6 inhibitor. So we do know that 40% of our patients would have a PIK3 mutation. We have data from the SOLAR study, which in a PIK3 mutated population clearly showed that the addition of alpelisib to fulvestrant showed a benefit. We have a much smaller BELIEVE study, which also in a post CDK4/6 setting actually showed that the addition of alpelisib continued to benefit these patients who do harbor a PIK3 mutation. So very quickly to my panelists, and I'll start with Vineet and then I'll go to Preeti. You do PIK3 mutation testing. Would you use archival tissue? Would you use a fresh biopsy? Do you rely on liquid biopsy? So 3 questions quickly, Vineet, and then Dr. Preeti.
So yeah, I'm happy to use archival tissue actually, and but if the tissue is not available, I do liquid biopsy. If liquid biopsy also fails, then that is the time I do a fresh biopsy.
And Dr. Preeti, are you happy with the RT-PCR or would you go in for an NGS?
PCR is okay. Yeah, if patient is affordable, then why not NGS?
So if the patient is affordable, you go in for NGS. Honestly, I rely on RT-PCR in most of these cases. I think it's a cheaper test, faster test, and while an NGS may actually end up throwing some more alteration in a PIK3, which may or may not be targetable. But clearly, so back to Dr. Nagendra, you have a PIK3 mutated patient, is a candidate for alpelisib. What are your considerations? Would you start all of these patients on alpelisib with fulvestrant, or what do you watch out for?
Right. So as you correctly mentioned, 40% of patients, ER/BR positive patients, will be having PIK3 mutation. So we are having one SOLAR-1 trial in which Victo or alpelisib was used with fulvestrant. So obviously this will be the choice of drug post those patients who have been exposed to CDK4/6 inhibitor up front. and they have progressed, I'll be happy to use alpelisib. As far as consideration is concerned, I'll be watching out for hyperglycemia because this drug is famous for increasing blood sugar levels. Second thing is rash is what I have to watch out for, and diarrhea and stomatitis, as you mentioned in the slide. So if the patient is already diabetic, I will be taking endocrinology consult before starting the application, and I will closely monitor. Right.
So, Dr. Pankaj, your thoughts, your experiences with Pluvicto in this setting?
Sir, initial experiences were scary when the sugar used to rise like within 500. We used to tell patient it will rise, but we were ourselves alarmed that they are rising so much. And so we actually now are more selective. The patient can really monitor the sugar levels, is not from village or something like uneducated, that patient will land up in some trouble. Then we assure that the patient will be able to monitor the sugar levels, and the baseline HbA1c are good. And in fact, in all of my patients, I start metformin, though not as per recommendation. Antihistamines are recommended to be started prophylactically, but I preferably start even the metformin as well, because all these patients I have seen that they actually need some sort of oral hypoglycemia and plus minus insulin. So this is the way I go around. The performance status is good, education level good, then I start this.
I think you spot on. I have had similar experiences, and I think what I've realized is that's very important to not only talk to your endocrinologist, but actually discuss what are the management strategies when it comes to managing hyperglycemia. Sometimes they jump to some drugs very quickly. It's very important to talk, and I fully agree with you. I think metformin and then insulin to be reserved for grade 3 and grade 4. And it's very important to talk to their dietitians as well, because I've had patients who practically put on a diet which was so bad that they started losing weight when the sugars went up to 500 or 600, where not such a strict dietary restriction, some modification of the drugs could have actually managed. So I think yeah, Manish,
there is no harm in starting the patient on metformin, especially after the early stage breast cancer CCTG MA32 study. They are thinking of metformin being quite effective in breast cancer as well.
Yes, you are right. I think again, I think it's more about getting the hang of how to manage and then being hands-on. And I think there's also a paper, so I've skipped that slide, but rash being an issue, and there's also a paper saying that prophylactic antihistaminics may actually prevent a lot of rash and thereby significantly improve quality of life for those patients who do end up receiving alpelisib. Anyways, Dr. Preeti, you can come in, or Manish.
The bigger question is what dose you start with.
Yeah. So what dose do you start with, Manish?
Not more than 200.
Not more than 200. Nagendra, your thoughts on that? Do you start full dose for a younger patient, go on to a smaller dose for an older patient or a diabetic patient?
So grading should be very much clear as far as sugar level is concerned. Less than 160, 162, 250, 250, 600, 600 beyond. Grade 1, grade 2, grade 3, grade 4. So grade 1 will start with metformin with OD dose, right? And then escalate to BD if it is grade 2. If grade 3 is there, then
I think they're talking pre-toxicity.
Yeah. So you're spot on with the management. The idea was, the patient is a known diabetic, but the sugars are okay. Do you start with full dose? Do you start with half dose? What is your percentages?
Right. So it depends on the grade only. Like lesser the grade, you lower the dose you start and then escalate depending on the sugar level. Always involve your endocrinology colleagues in effective management of sugar levels. That's the best way out.
Vineet, your thoughts?
But I think you have to tell your endocrinology colleagues that not to start with insulin.
Yes,
you have to actually tell them this is Pluvicto.
Exactly.
They don't have much sense of the drug till the time you actually educate them that this is Pluvicto and you got to use pioglitazone, metformins, and up the dose of metformin rather than going on to insulin.
Yeah, so in fact,
I will say one thing.
Send the management guidelines to these to my endocrinology colleagues before sending them patients. And this is what the guideline recommends for the management of Pluvicto associated hyperglycemia. Vineet, you were saying something.
Yeah. So in the Pluvicto in SOLAR-1 trial, there are only 4% diabetic patients, and the drug dose reduction is 50%, and the drug discontinuation is 25%.
HbA1c should be less than 6.5%.
Yeah. So I would say even for non-diabetics,
less than 6.5%.
Yes.
And I'll tell you that almost 20% of your patients are diabetic.
Yep. So my point is that even for non-diabetic patients, I think it makes sense to start at a lower dose because,
I agree.
what is the harm in starting at 200 or 250 mg and escalating rather than, landing up in the hospital with uncontrolled hyperglycemia. So what my practice is actually I start at 200 or 250 and I escalate. That is what I do. So I'm not sure whether anybody else also is doing that.
So how
but
do
I think
you,
that is
how
a good
frequently do
approach.
you monitor? How do you escalate? Vineet? Do you
So
ask the
yeah,
patient
so
to come back
I
in 15 days?
2 weeks, yes. After 2
2
weeks,
weeks.
if the sugars and all are fine, I escalate.
You would escalate.
But,
Pankaj?
Sir, initially in my practice, I used to start with photos, and after some bad experiences, I'm using to.
Now, the way this discussion is happening, I think everybody who's listening in is going to start at lower dose, I suspect. Nagendra, you were going to say something. So, and after that, we're going to have final thoughts before we conclude.
So only one thing I have to add there. Whenever I start, obviously, I always tell patient attendant to buy a glucometer at home. First thing. Second thing, maintain a small diary. Enter the sugar levels whenever you are checking. Just don't check it and leave it. Document that. Whenever you come to OPD, show the diary so that we'll come to know how the glycemic control is in last 4 weeks or 2 weeks whenever they are visiting the OPD. So this is what practical recommendation which I will tell the patients. And
I think you have
I
to
will check the
counsel about
compliance.
diet. You have to counsel about their
Perfect.
workouts. You have to also counsel about taking metformins and also measuring their sugars. It's a combination. It just doesn't work out with just measuring sugar. You have to tell them about diet. You have to tell them about workout, and you have to tell them everything.
Maybe the company needs to come up with some assistance
That's why
program
we are
like that.
consulting endocrinologists. They are telling
That's
this
why
only.
they have a dietitian who can counsel about the diet
So
as
maybe
well.
the company should
But
come
I
up with
guess
some assistance program.
lifestyle is an important issue for any hormone receptor positive breast cancer. Dr. Preeti, last thoughts, and we'll then hand over back to the organizers. I think Dr. Preeti is not here. So any last thoughts from the panelists? We've heard from Nagendra. Vineet, any last thoughts, and we'll go back.
So one major thought is actually with regard to Pivicto. I would say that the diabetes actually is the most common severe problem we are actually facing. So if a patient actually has very high sugar and you think they are not good candidate for Pivicto, I think you can give them everolimus instead of Pivicto as a combination with fulvestrant.
Everolimus
That
causes
data is also not very
hypoglycemia
bad.
as well.
Everolimus also
Yes, but
causes hyperglycemia, but I guess
not as bad as Pivicto.
Yeah. Agreed. But at the same time, I don't think we have data for everolimus in a post CDK4/6 setting, very similar to the phase 2 data for Pivicto, but I guess we have to do with what we have to do. So I think with that, I thank all my panelists, Dr. Nagendra, Dr. Pankaj, Dr. Vineet, and Dr. Preeti, and I think Manish also pitched in. So thank you as well for that. And with that, I'll hand the stage back to the organizers. Thank you again. Thank you.
Thank you, sir.
Thank you, Dr. Devratharya.
Thank you, everyone.
Ekta, I will just say a word of thanks. Thank you, Dr.
Yeah, ma'am. I was.
Excellent panel discussion. I do agree that Pivicto is difficult to handle, and patients' compliance and education goes a long way. Thanks to all our presenters, the moderators, and the discussants for an excellent program today. I think we do need updates on San Antonio breast cancer trials presented in December 2021 to manage our patients better on a Monday morning. With these words, thank you for staying back. We are 20 minutes late, but I think that was expected. And thanks once again to the organizers, to the event organizers, and to all the participants and the faculty. Thank you. We look forward to seeing you tomorrow. A similar time, 6 to 9. Thank you.
Thank you, ma'am. Thank you, Dr. Ramesh Sareen, ma'am. So support team, can we go good night and support good night, everyone. And support team, can we go offline?
We are offline.
Okay. Good night, everyone.